like to use the word. Why are you so much bothered about these three things?
What
And which are the drugs?
Drug intake.
Please keep your
Drug intake is theoretical, ma'am.
Yeah, can you tell me one or two drugs that can cause some problem?
Chloramphenicol, vancomycin.
Just 1 second. Sorry, can you see my screen? Yeah. Can you see my screen?
Yes, ma'am.
So starting with short case 1, a 48-year-old male, obese, diabetic, on insulin, metformin, CKD, hypothyroid, past history of heart transplant. So those transplant is not going to be a very common case in the EDIC 2. That is what they have told in one of the, you could say, preparatory courses of ESICM. But we still wanted to put just for an idea. He's been on tramadol, tacrolimus, and mycophenolate and prednisolone. He presents with confusion, breathlessness, and desaturation. Denies history of fever. On clinical examination, he is drowsy, confused, saturation of 96% on 2 liters oxygen via prongs, right basal crepitations, a BP of 110/52, and he is dehydrated. This is the ECG which was shown, which is sinus tachycardia. And if you can see here, the QTC is prolonged. Okay. There is nothing else major in the ECG. When you do not get the boxes and it is difficult to calculate at the intervals, if you look, the T is more than 50% beyond the RR interval. Okay, so this indicates that the QTC is prolonged. You may not be expected to give the milliseconds in which it is prolonged. The chest X-ray showing haziness on bilateral lower zones with more of the right side, which is probably a consolidation. And ABG with a respiratory acidosis as well as a combined metabolic acidosis. You need to quickly calculate your anion gaps. Sodium is low, potassium high, lactate of 9.4, sugars are low, hypoglycemic, and urea creatinine is raised. So what do you think is the cause for confusion? Now there are multiple reasons. There is hypoglycemia, there is uremia, there is hyponatremia. There could be some infection which could be septic delirium based on the X-ray. It is pneumonia mostly, or it could also be meningitis, encephalitis. And immunosuppressive drugs or any intracranial cause is also very common in any immunosuppressed patient. ECG, as we discussed, has sinus tachycardia with prolonged QTC. The ABG is showing metabolic with respiratory acidosis. On an calculation, it gives a combination of high anion gap and a normal anion gap acidosis. The causes of acidosis, very clear. It is high CO2. It could be because of the lactate being very high. It could be because of acute kidney injury, most commonly in these cases. The probable diagnosis is right consolidation, AKI on CKD, delirium, and a component of congestive cardiac failure cannot be ruled out because both the CP angles were blunted. So possibly there was fluid also in the lungs. Possible opportunistic infections. So the question is very clear. They want you to tell us the opportunistic infections in which we do not, definitely will not say streptococcus pneumonia and all. Though in immunosuppressed patients also the most common cause of pneumonia still remains the pneumococcal infection. Then in opportunistic we will have CMV, which is more common in the second month. Aspergillus. Pneumocystis is common in 4 to 6 months after transplant, and nocardia usually after 1 year of transplant. How will you manage? When you say manage, you have to give the diagnostic as well as the therapeutic answer. So in this diagnostic would be doing a early BAL, swab, or even a sputum for culture and do a PCR testing. You should consider aggressive antimicrobial therapy, which will be for the community-acquired pneumonia as well as for the opportunistic pneumonia. So our choice of antibiotic will be third generation cephalosporin with macrolide, cotrimoxazole, ganciclovir, and adding antifungals to it. About continuing immunosuppressive therapy, of course, the steroids cannot be stopped, especially in the stressed situation. We should consider increasing the dose of steroids rather than reducing it, but especially if the patient is hemodynamically unstable. mycophenolate and tacrolimus have to be stopped. Tacrolimus can be restarted after looking at the serum tacrolimus levels. When we reduce immunosuppression, the risk is definitely graft rejection. However, heart transplant does not require a very high amount of immunosuppression, and these patients do well even despite withdrawing their immunosuppression. This risk of withdrawal of immunosuppression is much higher in renal transplant of all the organs. An immune reconstitution syndrome may also develop, and abrupt cessation of steroids may have its own complications, which are often undesirable. What are the issues related to cardiac function in a transplanted heart? In a transplanted heart, the transplanted heart, as we all know, is denervated, and that is why it has to respond only to the directly acting drugs or hormones which are present in the circulation. So the common that are compensatory mechanisms or the reflexes which are there in the heart, this usually not be present. So it is more sensitive to these directly acting drugs and will be less responsive, less able to respond well to the changes in the intravascular volume. So for this reason, we need to be very careful with our drugs that we give, and as well as like giving fluid will control the heart rate. All those aspects we cannot see because of the decreased reflexes. We need to be careful with our fluid titration because there is diastolic dysfunction. It is difficult to clinically assess response or to look at the adequacy of therapy. And premature diffuse obliterative coronary atherosclerosis occurs in these patients, which results in impaired ventricular function. Okay. So coming to Vignette 2, the patient was intubated, ventilated, fluids were given, vasopressors, inotropes were given, started on dialysis for his AKI and his acidosis. His CMV serology is positive, but the plasma viral load is negative. So now this serology indicates that there are antibodies in the blood, which need not indicate that there is active infection. It just indicates that probably at some stage the patient has been exposed to CMV in his life, and it is inadequate to say that it is CMV infection, and we need positive viral load to say that this could be a positive CMV infection or active CMV infection. And usually for the CMV viral load, we usually prefer a BAL test to be done, and a PCR can be done for an early report or early result. How do we diagnose? So we need to look at the two things, either at the viral load, or direct detection of the antigen or the protein PP65 using monoclonal antibodies. This is sensitive, as it is quantitative, but it requires sufficient white cells in the peripheral blood. PCR assays, as I said, they have a rapid turnover time, and that is why they are very good. However, they are not very standardized. Treatment options available today are ganciclovir. Valganciclovir is the new drug which has come, which is much better. Then we have foscarnet and cidofovir. Okay, so this patient got confirmed with CMV pneumonia. He was treated with ganciclovir on SLED. However, he continued to be of low GCS, and a plain CT was planned after initial stabilization. So this was the CT scan given. However, it was very difficult to see that there was actually some hyperdensity at the back, which indicated the dense clot sign, and which is a sign of superior sagittal sinus thrombosis or cortical venous thrombosis. The risk factors for cortical venous thrombosis are thrombophilic states, dehydration, heparin-induced thrombocytopenia, intracranial hypotension, head and neck infections like mastocytitis, sinusitis, otitis media, meningitis, cerebral abscess, or empyema. The treatment is to reduce the ICP, look for any seizures and to correct them, and of course to give anticoagulation. The complications which we often expect is having seizures. Often they are intractable seizures because of them. Then we have communicative hydrocephalus, focal cerebral edema, intracranial hemorrhage, the clot expansion or propagation, which can increase the size of infarct. So this case was very short, but we need to remember that if there is any question which is mixed in the exam or which you don't answer, for instance, if I am giving the exam and I'm given the CT scan and I just say that there is poor gray-white differentiation and I don't look at the dense clot sign, my all further questions are deleted. I am not being asked those questions. So my exam actually ends at the point of asking the CT scan. So often we come out and say, my exam was very good and I answered everything, but you may actually not answered most of the questions because of this reason. Okay. Any questions on this mock test, short case 1? You have anything to say, Sampath? Are you there?
Hello.
You have anything to add?
No, ma'am, you have covered everything, almost everything. And I have written down some points of suggestions. I'll speak later on.
Okay, great. So I'll quickly go on to short case 2. This was again a long case made short, but all these cases which were there in the mock 2 were actually asked in November 2022 exam. Okay, so we have made it with the help of people who gave the exam. Okay. So short case 2 is a case of trauma in which a 42-year-old alcoholic male with complex psychiatric disorder had a history of fall from 200 meters with flexion injury to his neck. When he came to the emergency, he was conscious with a GCS of 9, was agitated, uncooperative, systolic BP of 80, pulse of 48. 218-gauge IV cannula was secured and 1 liter of balanced fistula was given. He was intubated with the use of manual inline stabilization. On arrival to the department, he was sedated. There is no additional information which you can get, but on arrival, you see that he has an oral endotracheal tube, which is fixed at 24 centimeters on the lips. He was on volume control mode with FiO2 of 50%, PEEP of 8, tidal volume of 500, respiratory rate of 17, IE of 1:2, a P plat of 15. Chest seems to be expanding normally. No surgical emphysema, rib fractures, breathing sounds equal. Weak pulse, bradycardia, and warm peripheries. GCS is E1, M5, and VT, bilaterally equal pupils, sluggishly responsive, occasionally triggers the ventilator. Cervical collar in place, abdomen is soft, not distended. Bleeding laceration is seen on the left popliteal fossa, and 2 lacerations are also seen on the left elbow. There are no obvious fractures or deformities in the extremities. Bladder temperature is 32.7, and no other injury is noted. 1 liter of warm saline is given. An arterial line is inserted into the right femoral artery, and invasive BP is showing a 86/43. The blood samples are obtained from the arterial line, show the following values. So we have the XTEM and the FIPTEM here, and ABG, which shows a significant acidosis again with a high lactate, and PF ratio of 150. Sugars, which are comparatively very high, but all other factors except for a little high potassium, all other things look quite okay. Okay. Images of the fast scan, the left thorax is showing a hemothorax, and the right thorax looks quite okay or normal. So diagnosis, again, we need to remember that this is a case of polytrauma. We should not rush to the diagnosis of saying that there is something in the chest, or we have to give a complete diagnosis when it comes to the diagnosis, including all the organs. So there is polytrauma with suspicion of traumatic brain injury, cervical spine injury, shock, thoracic trauma, or traumatic. So polytrauma, which includes brain or spinal injury, which is suspicious, a thoracic trauma because we can see a hemothorax, which is with hemodynamic instability and accompanying metabolic acidosis. The causes of shock in this case could be definitely hemorrhagic shock. There could be because it is a chest trauma, there could also be cardiogenic shock adding to it. But because of cervical spine trauma, there could be adding neurogenic shock. The spinal shock will per se not come in this. This is our error. I will delete it. Okay, how do we differentiate between a spinal and a neurogenic shock? Spinal shock is basically the motor function or the sensory function which is lost. It is not related to hemodynamics. And neurogenic shock is hypotension with bradycardia due to loss of sympathetic tone. So which major trauma patient should you have C-spine precautions? So which trauma, this question means that anybody, because I saw that many people could not understand this question well. So which case of trauma would you say that this patient warrants being given a C-spine stabilization? So anybody who has significant distracting injuries, anybody who's under the drugs or alcohol influence, who is confused, uncooperative, has reduced consciousness state, anybody who has a spinal pain or has some sensory or motor weakness in the limbs, they warrant being given C-spine precautions or C-spine stabilization. Assessment of the C-spine injury is mainly done by the Canadian C-spine rule and the nexus criteria. The cervical spine is immobilized either using a hard collar, and the airway needs to be assessed after applying this hard collar. But if we are on the field, we can even use sandbags to stabilize the cervical spine. What precautions would be necessary for intubation? While intubating, we need to make sure that we remove the hard collar before intubation and use a manual inline stabilization. These patients, we should anticipate a difficult intubation, also a full stomach, so we should consider rapid sequence intubation. They can become severely hypotensive after intubation, so fluid resuscitation is a must and should keep a video laryngoscope standby. What should you do if a patient in cervical spine precautions with unprotected airway starts to vomit? So when this was asked, many of you all said that we would intubate, but it would be too quick to intubate somebody who's vomiting. What they want to ask is, what would you do if they're vomiting, and how do you protect the airway in the when they suddenly start to vomit? So before we intubate, we just have to log roll them to one side, okay, and make sure we suction off the vomiters with a huge catheter, which is usually a Yankure catheter, a wide bore catheter. And if there are less people to do a log rolling, we can consider putting the patient in Trendelenburg position with the head of the bed being down. Since this patient has arrived to your hospital, what are your initial steps of managing? He's hemodynamically unstable. He possibility has chest trauma. We do not know about the pelvis status. So we will keep doing a serial E-fast analysis to look for any bleedings anywhere, apply pelvic binder, preferably do a CT scan of the whole body using the trauma protocol, use a blood alcohol level and tetanus prophylaxis. Interpreting the E-fast. E-fast is showing a left-sided hemothorax, no collection on the right side or in the splenorenal pouch. Next step, it would be for this hemothorax, we have to put a chest drain on the left side, repeat the fast scan and expedite doing a trauma CT scan. How do you insert a chest drain? If you have not mentioned chest drain above, we will be skipping this question. So always when you say, how will you insert, when they're asking you steps of doing something, you can always add a point that I will make a plan of or a protocol to intubate, which will fetch you 1 point. Okay. So we usually use the 4th or 5th intercostal space in the triangle of safety going towards the upper margin of the lower rib. So this is called as a good hole. Then good size of the tube. If somebody asks you what is the correct size of the tube, then it is 4 times of the ETT size of that individual or of that age. Good stop is we have to advance at least 4 centimeter mark, or the last hole is 4 centimeter inside the chest cavity. Okay, so once the last hole, so much so that the last hole should be 4 centimeter inside. Analyzing the TEG, there is hypofibrinogenemia. As you can see, a very thin line in the fibgin. And however, there is no fibrinolysis. Okay. How will you correct? We have to replace this fibrinogen. We can give antifibrinolysis by tranexamic acid. Tranexamic acid has shown to have a role in trauma for all cases, even before the TEG is done. And it should be given in the first 8 hours of the, rather first 3 hours of trauma, and maybe repeated every 8 hourly. And then massive transfusion protocol with a 1:1:1 ratio. So for this patient, a central line was inserted in the right femoral vein. He received 4 units of warmed O-negative blood, 4 units of FFP, 4 grams of fibrinogen, 1 gram of tranexamic acid, and more blood products were ordered. Large bore intercostal drain was inserted into the left hemithorax, which drained 2500 ml of blood. It stopped draining and a chest radiograph is performed. Following this, the oxygenation improved, blood pressure transiently improved. However, it again dropped to systolic 85, and he continues to be bradycardic with a heart rate of 50. His blood alcohol levels are 0.2%. Whole body CT scan was performed and shows a CT brain normal, CT chest, multiple rib fractures without any flail segments. Nothing in the CT abdomen, and the CT spine is shown below. How would you manage this thoracic trauma? Now, this is a torrential hemothorax, and we need to keep a watch or monitor coagulation studies, give massive transfusion protocol, correct his calcium and correct the lethal triad of coagulopathy in trauma, which is keep the patient warm, correct his acidosis. What abnormalities can you see in the CT image? We have to calculate it well, that it is the vertebral level. A quick calculation will show a C6 spinous process fracture. The arrow is marked there. And a C7 in the body is showing a teardrop fracture. And there is a shift or the anterior listhesis of the spinal cord, vertebral column. Other signs of spinal cord injury which might be present is we have to look for priapism, loss of anal tone, abnormal reflexes, sensory motor level, or diaphragmatic breathing, which will tell us that there is a possibility of nerve injury as well. His reduced GCS could be because of the alcohol, because of high blood level, despite the CT brain being normal. What is your next plan? Get the neurosurgeons early for spinal stabilization. Make sure you keep a high MAP to improve the perfusion to the spine and to improve the neurological outcome. The MAP target is more than 85. Immobilization to prevent any further injuries. Correct the bradycardia either with atropine or beta agonist, and start vasopressors. So what is the role of steroids? When they ask you the role, they are basically asking you what are the advantages, disadvantages, and what you would do. So all 3 points you have to answer. You just can't say that there is no role. You have to answer why there is no role and what have the studies shown, and eventually what would you do. So when I'm asked the role of steroids, I would say It is not recommended in acute spinal cord injury. However, it can be considered from case to case basis. But if it is administered, it has to be administered in the first 8 hours. It has not been shown to have any clinically significant benefit. Instead, it has shown to have increased risk of adverse effects in the form of hyperglycemia or infections or pulmonary embolism. What is the role of therapeutic hypothermia? No evidence as such in any of the studies which is clear. What are your concerns at this stage? Since it is a spinal cord chest injury and combined polytrauma, one thing is maintain normothermia, catheterize early so that we can monitor it, protect the gut, give early nutrition, pressure sores, give a thromboprophylaxis ASAP if there is no other contraindications. Will you be giving antibiotic prophylaxis in this patient? Since any closed trauma patient, we don't need it. But here, since we are doing a lot of instrumentation, we would need it. A single dose may be required for instrumentation, may be repeated further. However, this patient also has laceration, so he warrants a prolonged surgical prophylaxis. He underwent a urgent anterior spinal fixation of the cervical vertebra within 5 hours of admission. Popliteal wound was debrided, suture, spine was stable, forced fixation, no further movement restriction, started on amoxicillin, clavulanate as surgical prophylaxis as well as for his wound laceration. Remains on the ventilator, 5 mics per minute of NORAD is required to keep a MAP of more than 80. Neurosurgeons advise for chemical prophylaxis after 72 hours and the chest drain was removed on day 3 and the wound site was clean. On day 4, he's intubated. He is on pressure support CPAP with a pressure support of time, 10. ET secretions are dirty, brownish, BP is 110/60, which is unsupported with a pulse of 78. He's obeying intermittent commands. Power is on the upper limb is 2/5, on the lower limb is 3/5. A bulbocavernous reflex is present. His temperature is 39.5 degrees Celsius. What is your diagnosis at this stage? So change in the secretions indicates a ventilatory associated pneumonia with fever. And so we can say either of the answers, hospital or ventilated associated. How will you investigate? We send tracheal aspirate, gram stain. BAL may be considered, gram stain as well as the culture sensitivity. Full septic screen in the form of other cultures, CRP, PCT can be sent, and the antibiotics have to be upgraded as per the local antibiotic flora. So what is your choice of antibiotic? I will give it as per the local antibiotic flora, preferably either a cefepime or a beta-lactamase inhibitor in the form of piperacillin or tazobactam. How do you know that his shock has recovered, spinal shock has recovered at this stage? So a return of the bulbocavernous reflex at this stage indicates that the spinal shock is reversing. Okay. So he was started on cefepime, became afebrile in the next 2 days, vasopressors weaned off, but he was difficult to wean. He's paraplegic, but significant intercostal weakness is present. You start counseling the family that he may need prolonged ventilation and tracheostomy. Family is not agreeable and needs more time to think. And on day 9, you notice that he has again developed fever, which is associated with hypotension. You resuscitate him with cautious fluid boluses, start him on noradrenaline, 12 mics per minute. Upgrade antibiotics to meropenem and vancomycin. On examination, you notice a wound discharge from the neck and cultures have been sent which has growing MSSA. What will you do? So we know that there is an abscess there. We need to look at this abscess and get it drained. So I would do everything that I would look for an imaging first to look at the extent of the abscess. Is it extending into the epidural space? I would notify the surgeons because it may require IND and de-escalate to cover MSSA specifically, which is meropenem is not a very good, or rather vancomycin is not a very good choice for MSSA. We need to de-escalate to either giving flucloxacin or cefazolin. The dose of flucloxacin is 2 grams 6 hourly and cefazolin is 6 to 8 grams once a day. Or it's not once a day, it's twice a day, but you have to give it 6 to 8 grams per day. Will you consider tracheostomy now? No, because he's already having infection there. We would not do any further instrumentation there. There would be a potential of infection. We would have a multidisciplinary team discussions and inform the family about the discussion. So the neurosurgeon is consultant and he says, no, we would not do a tracheostomy for at least 4 weeks due to infection. How will you manage? So we would discuss this with the family, tell them about the pro and cons of having a prolonged intubation, say that you would be continuing daily spontaneous breathing trials, do a rigorous physiotherapy and maintain a good nutrition so we can wean him off in either ways. How would you plan weaning from mechanical ventilation? We would use a bundle to facilitate respiratory weaning. An abdominal contention belt can be used during periods of spontaneous breathing or other procedures when he is erect. Active physiotherapy, a mechanically assisted insufflation, exsufflation device to remove the bronchial secretions. Aerosol therapy is done combining anticholinergics and beta-2 mimetics. His family is now worried about the recovery and possibility of ventilator dependence. The NOK requests you to discontinue therapy. What is your take on it? So first of all, since the patient is fully conscious, we would want to check the patient's autonomy. What is his wish? And we should respect or explore his wishes. A multidisciplinary discussions can be continued with the family. All these discussions should be clearly and formally documented. Allow more time for the ongoing discussions and inform them about the rehab sessions. And if it is still persistent, we may consider seeking senior advice, institutional advice, including legal and ethical advice from the hospital administration. After another week of treatment, the patient is afebrile, still on the ventilator. You want to shift him to a step-down unit. What is the advice that you would give? So when we shift them down, we have to ensure that there is regular tracheal toileting. Ensure that the patient is on humidified circuit, preferably with a water humidifier. Increase the PEEP so as we can recruit the available alveoli. Daily weaning trials, spontaneous breathing trials. Upright position, change of position, ensure good feeding, nasogastric tube in position. May consider using a nasojejunal feed. Ensure good quality and regular hygiene, regular chest physiotherapy, and DVT prophylaxis. This patient was given daily weaning attempts and was finally extubated without the tracheostomy. Any questions on this?
Salam.
Hello, Dr. Almeri.
Thank you for your debriefing.
You're welcome.
Regarding Rotam,
Yeah.
Rotam, it showed only fibrinogen needed. And in the answer, we give all. Why?
So we gave only fibrinogen. We gave antifibrinolytics for the fibrinogen. We did not give. See, when there is massive bleeding, that is 2500 of blood, you cannot give only one product. Okay, we have to give a massive transfusion protocol.
That's why one side we are giving massive transfusion protocol. Other hand, we are sending Rotam.
So see, when I'm seeing Rotem, if you look at the answer with the Rotem, I will share the screen again. So we are specifically giving fibrinogen. We are giving antifibrinolytics, okay, which is a must in anybody who's having fibrinogen deficiency, right? So, and then if we are needing more and more blood products, that is, if you need a lot of PRBCs in a massive bleeding patient, you have to maintain the protocol. Otherwise, you will have dilutional coagulopathy with other agents.
Even if you see the vignette 2, they mentioned already given blood, plasma, platelets, fibrinogen, tranexamic acid, everything.
Yes. We have given everything as per the massive transfusion protocol. That is, we have given blood, FFP, fibrinogen, so cryo, but we have not given him any platelets.
So we should answer like.
So you have to give a specific answer based on the Rotem that is there. So because he's hyperfibrinogen, you have to give the specific answers. But yes, if he requires a lot of blood products, then we would also prefer to give a massive transfusion protocol to be followed.
Okay, good.
Okay. So we'll go ahead with the long case one. Sekat wants to do the long case one, so I think I'll wait for him. In the meantime, I think should I do the CBS?
Please.
Yes, better to go ahead with the CBS.
Yeah, we'll go ahead with the CBS. Just a second. Just 1 second.
And this video will be available for us to revise.
Yes.
CBS also.
We will be putting it up. But like how we did it for mock 1, that we divided it into sections, we may not be able to do that. We'll put it as one single video.
Okay, sure. Thank you.
Just 1 second, I'll just. We'll start with the images. Okay. So we'll go ahead with the images. This is an alcoholic which is admitted with massive hemorrhagic bleeding, shock from GI bleeding. So possibly it is varices. What is seen on the X-ray? So if you can see a gas bubble kind of behind the heart shadow, and this is a Sengstaken Blakemore tube which is got misplaced, and the gastric balloon is in the esophagus. So this is a misplaced SP tube, and the risk with inflating the gastric balloon in the esophagus, which the risk is the rupture of the esophagus. So esophageal rupture is the answer. A 60-year-old male is admitted to the ICU immediately post-operatively following retroperitoneal lymph node dissection involving the diaphragm. He is acutely short of breath following extubation, which is what is seen on the X-ray. So whenever you get a CBS, please read the scenario. Take a second extra to read the scenario and understand what it is. Okay. Here, if you can see, it is clearly mentioned that the dissection was involving the diaphragm, and he's now having a breathlessness with haziness on the left lower zone, and plus there is the left diaphragm is little up. Okay. So this is causing a shift to the opposite side. And since this side the diaphragm is involved, the mediastinum is shifted to the opposite side. This is a huge pneumothorax. I can't expand it. Just let me see if I can. Can you all see it clearly, the pneumothorax? There's no possibility to expand it. Okay.
Yes,
so you can see an ICD here. Despite the ICD, the pneumothorax has not opened up completely. Okay. There's a flattening of the diaphragm on the right side. Okay, so there's what you need is this is a right tension pneumothorax. You need to do a right needle decompression with a drainage, maybe another drain to be put in the anterior level, and maybe the right drain can be pulled out so that it is in the right position to drain that pneumothorax. A 23-year-old biker who is present with a high-speed collision. His GCS is 8/15, tachycardic, hypotensive, cold clammy peripheries with multiple bruises. EFAST shows the following. So we can see here in the Morrison's pouch, there is evidence of free fluid, and this patient is already hypotensive. We need to, when you say what you do, you have to quickly answer that I would go for ABC, I would stabilize the hemodynamics, massive transfusion protocol, correct the lethal triad, give tranexamic acid, and involve the surgeons for laparotomy. So all these questions have to be very quickly answered in a single statement so that you don't waste your time, but you have covered everything that you need. 68-year-old male with pneumonia and develops right-sided pneumothorax, which was drained. His saturation still continues to remain 88% on an FiO2 of 0.8. What does the chest X-ray show? So this patient is already intubated. Okay, and he has a right-sided ICD. Okay. Now, if this image is not very clear, but if you can see see more closely. Okay, we do not really have anything on the right side. Maybe a kind of a double diaphragm sign, gas under the diaphragm, which I initially thought. But when we look closely, there is a consolidation on the left side, and we see the nasogastric tube, which is present in the left main bronchus. So this speed has probably caused pneumonia on the left side, which has led to his breathlessness or desaturation. So NG tube in the left main bronchus, left basal collapse, a large gastric balloon, ET tube in position, and right CVC line in position. Describe the abnormalities present on the CT scan in this diabetic patient. What are the likely organisms? So this is the right kidney, which is showing air bubbles, gas bubbles inside with dead tissue, which indicates there is acute pyelonephritis. So it's a right, well circumcised, heterogeneously and enhancing lesion in the upper pole. Locules of gas are present at the periphery and within, which is emphysematous pyelonephritis. Likely organisms mostly are gram-negative. E. coli and Klebsiella take the main toll. Other organisms may also be there, like Proteus, Pseudomonas, Streptococcus, or mixed. Management priorities is resuscitation, giving IV antibiotics, and urgent percutaneous drainage or nephrectomy. A 32-year-old male, motor vehicle accident, acutely dyspneic, and saturation remains 90% on FiO2 of 0.7. What is shown and what do you see? So this, if you see at the level of the I mean, just below the carina or little higher, where you're actually seeing the great vessels, you can see kind of a gas bubble. Okay. This happens usually when you have diaphragmatic rupture and gas, the stomach is in the chest, which causes a tension gastrothorax. So we have to decompress the stomach to allow the saturation to improve, and the treatment is urgent NG decompression. 70-year-old male with known alcoholic cardiomyopathy and pacemaker admitted with left lower lobe pneumonia. Blood cultures show staph aureus in 2 sets. A transthoracic echo shows a 30/4 floating vegetation in the right atrium, which is hanging on the pacing lead. Now in shock with worsening hypoxemia, what do you see? So the hint comes here from the staph and the vegetation which is there in the right atrium, and the patient has become hypoxic with some small lesions, and which is called as the feeding vessel sign, and this is seen in a septic emboli which occur because of staphylococcal infection. So bilateral septic emboli are present. There's a small left pneumothorax with a left basal infiltrate which is present, and there is bilateral pleural effusion. 69-year-old male, known case of CA esophagus, which was posted for surgery, suddenly developed sudden onset of breathlessness and hypotension. What do you see? So both these diaphragms are flattened. And if you can see, there's a lung border which is present. So there is bilateral hydropneumothorax with bilateral collapse of the lungs. The treatment would be immediately bilateral needle thoracostomy, ABC, and then finally needing a bilateral ICD. Now, if you would have answered this, the third question would be, at what level do you do the needle thoracostomy? So initially the needle thoracostomy was done in the second intercostal space, but as per the latest guidelines of ATLS, it says that it has to be done in the fifth intercostal space at the anterior axillary line. Interpret the CT findings. The CT scan is showing a ruptured IVC filter, a perforated IVC filter. 75-year-old male, chronic smoker, hypertensive, presence with breathlessness on exertion and left-sided chest pain on exertion. Interpret the image and name 3 complications because of that. So you can see there is a dissection of the descending aorta here, and this is a CT contrast or CT angiogram. And the 3 complications, usually either this dissection, the aorta can rupture, there could be a pericardial tamponade, there could be disruption of the aortic valve, or there could be obstruction of the coronary circulation, cerebral circulation, the kidney circulation, or even of the peripheries. Okay. This is all for the images. Any questions in images? Sekat is here. Sekat, we were waiting for you, so we started with CBS.
Okay. Sorry, going late.
Thought you would do the long case.
Much. Take it. Okay.
Any questions with the images? So you want to start the long case, Sekat?
So we are done with CBS.
We are done with 2 short cases and images.
Oh, images. We can finish off the CBS first.
Okay. So should I continue presentation?
Yeah, continue. Continue.
Just one second.
Maybe we can make the CBS one a bit interactive.
People are here watching. They are
No,
just asking what wrong did they do.
how many people on board? I think 12, maybe 7, 8.
Sampath are our team.
Yeah, so I will suggest everyone to turn on their camera, and this is the time that everyone should try to attempt. Because no one going to judge you or no one going to mark you, at least here. If you're doing any mistake, we can help you. Of course, we're limited with time. We have to think of that as well.
So are you all ready to participate and give us the answer so that we can eventually discuss and do it?
Yes, ma'am.
Yeah. Please turn on your camera, please, when answering. That would be good for everyone.
Okay.
This is the first case. Who's volunteering for it? So Parnika, you're smiling.
Or else we'll go alphabetically.
So Ahmed, say this first.
Yeah.
Yes.
You can do the first answering.
Actually, I skipped this ECG in the mock exam. So
Okay, next one. Who is
can
anyone
take
with B?
Come on, Sauparnika, you can do it.
No, ma'am, I also skipped that actually. I don't know.
I can try.
Yes,
Right.
please try.
So there is a sinus rhythm in the first beat, but there is bigamy extra systole most of the time. That's why it looks irregular.
Mhm.
So what is worry in this patient? It can develop to arrhythmias.
It can develop. Sorry, I didn't get that. It can develop
Arrhythmias.
arrhythmia. Yeah.
So can this T R on T phenomena?
Okay. So here you can see the inferior lead 2-3 ABF. There are some subtle ST elevation and some QF changes. So likely there is some inferior wall ischemia or AMI, inferior wall myocardial infarction. And likely due to this ischemia, there are couplet we can see. So this patient is at risk of arrhythmia, as you mentioned. What type of arrhythmia specifically? When we are answering, it could be VT or VF. So what would be the management consideration? ABC, fluid, as is like involving the infrawall, no vasodilators, no nitrates, urgent PCI, optimize electrolytes, and be vigilant if any arrhythmia develops. Okay, so we can show the answer. Any doubt? Just
Good.
tricky, that's all. You people know everything. This we see day in and out in our ICU, in our daily life. Just keep your mind open. That's all. Easy peasy. Next one.
So ECGs will be very difficult in the sense that we are not used to seeing so many ECGs. All we see is MIs. Just go systematically and most of the time you'll get the answer. I mean, in this, it was very, if you just say VPCs or ventricular premature beats, you're anyways getting 1 point. So keeping quiet anyways doesn't give you the solution. Okay.
Yeah.
Say whatever you can. It is a sinus rhythm, but intermittently there are many VPCs which are coming in couplets. And then you can, if you can notice the ST elevation, even if you mention that much, you have, you have half the job done. And when we have VPCs, yeah, we have to always optimize the electrolytes and there's a risk of ventricular arrhythmias. Simple. I mean, I would have got 4 points even without interpreting the ECG. Okay. So hit the ball at least. Don't take it ki yorker hai aur main marunga nahi.
Yeah. So, so this one is 30-year-old man with severe TBI, and the monitor showing ICP, MAP, CPP, brain tissue oxygenation and temperature of the brain. So what do you think where the regulation is lost?
Let me answer, sir. I think.
Is it Suhas or?
Yeah, Suhas, yeah. From the point just next to A, so when the both waves MAP and CPP are going and going up and down in the same direction, so that is when the autoregulation is lost.
So in short, so again repeat, you are saying MAP and ICP, right?
Yes, MAP and ICP, when they start going in the same direction, similar direction.
So we don't go by that. So the answer should be CPP and ICP. So where CPP is parallel to ICP, in that part, autoregulation is lost. If you see at point A and point B, they are going opposite direction. So CPP, so autoregulation are preserved in both that point. So the answer would be, in that part it is lost where CPP is parallel to ICP, not MAP. Answer should be with respect to CPP and ICP.
Okay, sure.
Okay. So you may get one, everyone will get one. No,
I
next
have
one.
a question here.
Yeah.
What is the point? We have to answer it on point A or point B because they have
No.
2 points there.
No, I have not mentioned here point A and point B. That's diverting your attention.
Okay. Okay.
If they mention where is the loss at point A or point B, then pinpoint it. So this is one of the edit question back in 2014 and 16 in that time period. This is only for diversion that we all will be thinking, let's answer A or B.
Yeah.
If you see both CPP and ICP, they are going opposite direction at point A and point B. But the rest part on the right hand side of the screen, you can see they are going parallel. That is the part where say autoregulation is lost. Okay. Any more confusion? No. Okay. So they can give any patient data management system related recording. So many answered cardiogenic shock. I don't know why, but this is a classical thing we see in tamponade. Heart rate going up, blood pressure coming down, ETCO2 coming down, lactate going up, CBP going up. So basically there is equalization of pressures happening within the heart chamber. So the treatment in any post-CABG patient, if you think that is a tamponade, the patient need to go to theater. There is no role of pericardiocentesis. Many answered pericardiocentesis, no. The chest is already open, they're closed with where it's not easy to do the pericardiocentesis. The patient need to go immediately to theater. Be mindful with the post-CABG patient.
I would have answered this question without knowing anything. The most common cause 12 hours later is a tamponade.
Yeah, and it's also
But your scenario gives you so much hint. I mean, I would have at least, because there is no negative marking, there is no harm in saying, it is a pericardial tamponade.
No, they mostly answered cardiogenic shock. But if somebody can explain why cardiogenic shock, this is an old EDIC question maybe asked in 2022 or some in that time period, before 2021 or 2022. Post-CABG patient, most common is tamponade. Cardiogenic shock can happen, but when they are giving hint at CABG, the first thing we are worried about tamponade, equalization of pressure. Okay, next one. Yeah. Well, okay. Can anyone volunteer, please?
Let me. 75-year-old male, known case of long-term diabetes mellitus and hypertension, presents with a sudden onset breathlessness and sweating. The ECG on admission is shown below.
What is the most important thing that is catching your eye here? Even not looking at the what questions they're asking.
ST elevation and AVR.
Good. ST elevation in AVR is a dangerous sign. That means LMCA block, left main coronary artery block. Other two conditions post-arrest, it can happen. It can happen in LED. So there is ST elevation in AVR and global ST depression. It has, so you can see the ST depression anywhere in the leads, all over the leads. There is no fixed pattern. If you see elevation in the AVR, close your eyes and say it's LMCA occlusion. It's an emergency. Mortality rate is very high. It depends on the ST elevation. I actually forgot the value, 1 millimeter, 0.5 millimeter, 1 millimeter, 1.5 millimeter. So proportionately, the mortality goes up. Okay, maybe we can reveal the answer. The next slide. It's very easy. You have to answer any two conditions. You can say LED, you can say post cardiac arrest. Even if you see in your daily life, post arrest patient, they sometimes show this type of ECG features, and we think it could be the arrest could be due to LED block. Send the patient to cath lab, they will find nothing. Okay, next question. Okay, many people, I think one of you answered is disconnection from the ventilator. What do you think? What's going on? Without looking at the stem of the main stem.
It can be disconnected, it can be cardiac arrest.
Anybody else? Anybody, please try. This is a time you should try.
There is an apnea.
Okay.
Breath holding episode.
May I request everyone to just turn on the camera? That would be great.
See this point.
Set tidal volume is, set respiratory rate is low and the patient is trying to inspire.
What is this?
Sir?
Here it is a esophagus.
Esophageal pressure shows that the patient is dipping down, so the patient is trying to inspire during the expiration.
During expiration, or is it an ineffective effort? The patient.
No, the patient is trying to inspire when the ventilator is giving an expiratory. The inspiratory valve is closed, so the patient is trying to inspire against a closed valve.
Okay, so let me make it simple. Don't make it too much complicated. See, the expiration already has finished here because it has touched the baseline or there is no autopip. Now, if you draw a line perpendicular to this point 3, you can see the patient next inspiratory effort has already started. But due to some reason, the patient is unable to trigger the breath. What that means? This is ineffective effort. When they're giving the P esophagus, it becomes very easy to tell patient is inspiring, but patient the ventilator is not delivering the breath.
Yes.
Okay. Any confusion?
Very difficult.
Not difficult. It's not difficult. When you have got the esophageal pressure here, it make it more easier. Suppose if I would have deleted this part of the picture and if I would given only these two, then I would say it become very tricky.
The negative deflection of the esophageal pressure says the patient is trying to initiate a breath, but it is effective. It is not happening. Okay, so the overcome breathing is going to increase. Okay.
Yep. Next question, please. Anyone would like to try? See, ARDS is the bread and butter for us. We need to know in and out because not only for exam purpose, but also we can apply all these things by the bedside in our daily practice.
Yeah. So the tidal volume is on a higher side. It should be should have been.
1 minute. So the question is, read the question. What they're asking. Don't jump the gun.
60.
Are you satisfied? No. Answer is no. Stop there. Examiner is not interested to know what settings are there. They mention, are you satisfied? Somebody will say yes, some will say no. When you will be saying no, then they will be asking the next set of questions. Why are you saying no? If you say yes, they will say, okay, they will skip to the next question. Now, so that's why you have to know where you have to stop. So when we speak more, we are losing time. They ask, are you satisfied? No. Stop. Wait for them. So answer is no. Now the next question was or is why? Very easy. We do by the bedside. They are not asking, how do you know that PP is optimal or not for that patient? Many answer the PP is high, PP is low. How do you know that? But what is more relevant, tidal volume is around 10 ml per kilo, high plateau pressure and high driving pressure. We don't know whether the respiratory rate is high or low. If they ask what's change you will do, you can say, I will optimize PEEP, but you can't answer, I will go for high PEEP or low PEEP without examining the patient. You can only use this term, I will be optimizing the PEEP. I will decrease the tidal volume because the tidal volume is high. And while optimizing the PEEP, I will look into the driving pressure so that it falls below 15 and respiratory rate accordingly to match the minute ventilation. That's all. It will hardly take 10 to 15 seconds to answer this. Because many people, many of you answered respiratory rate is high or something, plateau pressure, not plateau pressure, I think you mentioned, PEEP is high. It's very difficult to say the PEEP is high or PEEP is low. It may be that PEEP is low for this patient. So only one thing we can say, we can optimize PEEP. 14 PEEP may be maybe high, maybe low for this patient. We don't know. It's very difficult to predict from this picture. Any confusion? Just please don't jump the gun. That's the request. They are saying that's why the concept of the mock is that you should know where you should stop. No means no. Yes, then they will change the direction. They can ask you, okay, why? See, ask only if candidate says no to previous question. If you say yes, you would have skipped all these three. Okay, next question, please. So this is very easy. So the thing is that you have to calculate VTI, which is pi r squared. Height is the diameter. Height is a VTI. So the VTI is h. And when we do the plaques, which is shown on the left side, we have to measure the aortic root diameter, half it and square it. The raw value will be around 6 liter. You have to multiply it with heart rate. Pure calculation. You can say skip, come back to it because it's bit calculation thing. So what you can do, I'll come back to it later on. This is pure mathematics.
Guru has put a short video on how to do quick calculations in the CBS videos recently, a week back.
Yep.
Some simple math he has shown.
Yeah, whatever. Just you can say, as of now, due to the time pressure, what happened in the exam, already our heart rate is around 150. You can say, I'll come back to it later on. Nobody want you to go that you should land up in important VT or VF in the exam. Next question, please.
Are you also coming back to it later?
Oh, done already. It's the same. Okay, so expect one hemodynamic question in your main exam. Please, someone try to answer. Who else? You people have answered. Someone who have not answered yet. Dr. Shamogita, can you will you try to answer?
Okay, so the cardiac index is 7.45, stroke volume variation 6, SVRI 856. So the stroke volume variation predicts that there is no fluid responsiveness. SVRI is low and the PVPI is very high. So global end diastolic index 534. What do you want to ask? What are the current concerns? What do you want to do?
Do you think the cardiac output is
very
low,
high?
Very high. And SVRI is very low. In what condition you can see this type of thing? High cardiac output and low blood pressure, low SVRI in the context of this scenario.
Sepsis.
Sepsis post-laparotomy.
Anybody failed to answer is a vasoplegic shock. So with these parameter, two parameters, the SVRI and the cardiac output or cardiac index, whatever, I will say the cardiac output, you can say at least the patient has got a severe vasoplegic shock
Vasoplegic state.
or severe or septic shock, as evident by high cardiac output and low SVRI. Normal SVRI, I'm not talking about SVR. SVRI is around 1700 to around 2200, some say 1800 to 2300. They will give some value which is out of the range. They will not give a value close to that.
Okay.
Now, the trick is that here the GEDI is very low, which can think you giving more fluid in this instance because it is below 680 or below 700, whatever. Now, the next step, you have to look into the extravascular lung water, which is around 10 ml per kilo, but it is 22. Now there is a role of PVPI. What is PVPI? What is PVPI? Pulmonary vascular permeability index. So PVPI should be less than 1 in ideal condition. If it is between 1 to 3, it is likely hydrostatic pulmonary edema. If it is more than 3, it is
capillary.
It is permeability edema or ARDS. So even if the GEDI is low, will you give fluid in this scenario? Will you give?
No, I will not give.
You will not give. So because what are your concerns? Why are you worried with this patient? Because you are a consultant. This is an exam for someone who is giving in the final, who is in the final year. So what are your concerns? I would not give fluid because high cardiac output, 1, low SVRI, likely vasoplegic shock. Patient has got high extravascular lung water and PVPA, likely patient may be developing some extra pulmonary ARDS. SBB is below 10, but suppose if they have not given the ventilator parameter, if not ideal, you can't say that SBB is actually ideal for this patient. Anyways, here is 6 ml, PPA, fine, agree with that. So what would you do here?
And start some vasopressors, norepinephrine.
Patient is already on norepinephrine. You will add vasopressin. When you are adding second vasopressor, what you will add? Steroid. Steroid. Stress dose of steroid. So don't miss this thing. Steroid. Maybe now people say patient on 15 or 20 of NORAD for at least 4 hours, you can start steroid. If in the vignette, even in the CCA, they mentioned patient on noradrenaline for 4-5 hours, you can say, I will start steroid and will consider second vasopressin. So you can see the answer. Is it clear?
Yeah.
Any rule for Lasix or diuresis for him?
Can I go to the vignette, please? So now you say this patient is on 15 mics of NORAD. What is your usual practice? Would you give Lasix? And why you want to give Lasix in a vasoplegic shock? Patient is not in cardiogenic shock.
If there is increase in the ventilator requirement and he's start to be desatting or high setting, oliguric, and I have signs of volume overload.
Yeah.
In this case, maybe you will consider to give him diuresis. Even sometimes we can start CRRT or renal replacement therapy for him.
That's a reasonable choice, but there could be many. You can start CRRT, but why not furosemide? I just now mentioned you have to look into the PVPI. If the PVPI is more than 3, it is likely ARDS. If PVPI is between 1 to 3 or 1 to 2.5, some says it is hydrostatic pulmonary edema, which can be seen in cardiogenic shock. Here PVPI is 6 means patient has gone into some abdominal sepsis, which has led to extra pulmonary ARDS. I agree, negative fluid balance in ARDS can help with the mortality, but in this current scenario where the cardiac output is too high, SVRI is low, patient is having vasoplegic shock, Nobody will give furosemide. Maybe I can ask Dr. Guru, madam here.
See, when you're talking of hypotension, why do you want to give Lasix? I mean, it's about resuscitation. No? Why should the question come out about Lasix here?
It's not the first choice, but it is one of the management. As I told,
Yeah.
if he's overloaded, we can use it.
Ahmad, here, because the PVPI is high, it is more of the permeability. That is the reason it is, your Lasix is not going to decongest this.
Yeah.
The permeability is increased.
Yeah.
Yeah.
So when the patient is recovering, likely the patient is in the F phase of the septic shock. So when the patient will go into flow phase, then you can, and the vasopressor dose are coming down, then you can consider this furosemide. Where do we think of giving some negative fluid balance? Anyways, they will not be asking all this stuff. So you have to be very snappy and pinpoint. Okay, vasodilatory shock, permeability, pulmonary edema, likely ARDS. Even if you're telling ARDS, you'll get marks. And vasopressin steroid, no more fluid, optimize ventilation, antibiotic. Done. Hardly it will take. Look at the vignette, 20 seconds, answer 20 seconds. Done. Just read the first line, last two line, what they are asking, and then go back to the main vignette. Don't read the first, don't go into the vignette first. You will be losing time. Read the first. Okay. Old patient, post-emergency laparotomy, quadrant peritonitis. So back of the mind, oh, okay, this patient has got some sepsis or septic shock. Now go to the question. What are your concerns? Then go back into the vignette quickly. Automatically, you'll get your answer.
Okay.
Okay, next one, please. Okay, someone please try this.
So this is a regular broad complex tachycardia.
Why broad complex?
So because the QRS is prolonged, more
Count
than 100 milliseconds.
Count it.
Count on my computer.
So it is, if you can see, when you can't count like that, if you see most of the lead, it is only around 2 to 2.5 boxes.
Yeah.
How can you say it's a broad complex? It's a narrow complex tachycardia. So you are losing point when you are thinking broad complex. Recently, I had 2 days back, I've got a same patient with same thing, though the patient died. There's a different thing with right heart load, 150 kilos, OSA, stretching the right heart, causing this type of tachycardia.
It's an SVT with aberrancy.
Okay. So I will reveal the answer. Rather beating around the bush, can you go into the ECG? So you can see it is negative in the V1. So RVOT tachycardia is mainly happens in someone who has got no structural heart disease. Second is there is positive inferior axis. So 2-3 AVF should be positive. The first rule is it should be narrow complex. Second is no structural heart disease. Third is positive in 2-3 AVF. And as it is developing, as it is starting from the right ventricular outflow tract, it need to be negative on V1 because the vector is directed away from the V1. If you can remember the ECG lead, the V1 and the base of the right ventricle or the right ventricular outflow tract is there. As it is developing from there, the vector is pointed towards the inferior axis. So in this, no structural heart disease, narrow complex, positive in 2-3 ABF, and negative in V1. And the other one, if you can remember, is good. It become positive, the complex in the chest lead around V3 to V4. For this type of RVOT tachycardia, the treatment is adenosine or verapamil. Okay. Any confusion? Clear your doubts here now. I have similar type of patient 2 days back. We palliated that patient. That's a different thing. Similar. His right heart was stretching and it is causing this tachycardia. And he was every time the cardiac output became totally zero. He was actually not for CPR as per his wish. So, and he was automatically auto-resuscitating to his normal rhythm, going to 0 for 2 minutes and again going back to 150, this tachycardia, 150 to 160.
So this type of junctional tachycardia or not?
What is that?
It is type of junctional tachycardia, SVT.
No, this is a type of outflow tract tachycardia because the focus is in the outflow tract. RVOT tachycardia.
Okay.
I didn't understand your question. What are you trying to ask?
This it is junctional tachycardia or not?
Junctional tachycardia. You are asking whether it is a junctional tachycardia or not.
Yes, yes.
No, this is the tachycardia which is arising from the outflow tract.
It is not kind of SVT.
Is a type of VT, not SVT. Narrow complex VT.
Okay.
Okay. This question was given just to bamboozle you people.
So if it is if from the right ventricle, how adenosine or
That's the treatment of choice.
verapamil, yeah, I will try it as a treatment, but it will work at the EV node or the sinus, right?
Yeah.
So it will not affect the ventricle.
So as the tachycardia appearing from the ventricular outflow, see, I don't know that mechanism. I'm not cardiologist. Maybe you have to ask the cardiologist for that. I don't know.
Okay.
So RVOT tachycardia, if you can also search, you can read. You can see it's the treatment same as SVT, like PSVT, what we say, but it is a type. Yeah, it's a type of VT with narrow complex tachycardia. I don't know the mechanism, how it works, and I never searched. It is beyond my pay grade, I think. Okay. Yeah.
So it is usually a benign type of tachycardia. It is not really a VT.
Yeah.
Okay. It is found to be adenosine sensitive. I mean, to be very honest, I would not also be in a right position to say why it is sensitive to adenosine despite being a VT, but it is clearly mentioned that it is a benign. There are 2-3 points which come in the literature. One is it says it is benign. It doesn't usually, go into a VT or a VF, that it is not a malignant tachycardia. One is the other point, they say that it is adenosine sensitive, and usually there is no associated structural heart disease with it. These are some of the points which come as salient features of this tachycardia. And usually the final treatment for these tachycardias is catheter ablation.
Yeah,
okay,
ablation.
Beta blockers and calcium channel blockers are other treatments. And these days, beta blockers are taking more importance than a calcium channel blockers. So, okay.
Yeah, next one, please. Yeah, ma'am, maybe you can just, anybody want to try? What do you think?
Simple one, quick answers. Let us take more time on the difficult ones.
So here you can see the pressure support is too high. So the patient is taking too much of tidal volume. That's why he is compensating for his minute ventilation by decreasing his respiratory rate. Someone answered like maybe due to opioids and all those stuff. But if like due to opioid and all multifactorial, they will not be asking the multifactorial thing. If they ask, you can answer. This could be the thing. If if like opioid and all, the patient wouldn't have taking this 800 or 900 of tidal volume. There will be proportionate decrease in the tidal volume as well as in the respiratory rate or bradypnea, hyperventilation. Okay. Any confusion?
Good.
Okay.
So we'll go ahead with the biochemistry part.
Maybe you can lead the show.
Biochemistry was quite straightforward, and usually it is. I can see some smart smiles. If it clicks you, it clicks you. If it doesn't, then you should just let it go.
It will click you in the main exam. Don't worry about that. It will be big stream. Just.
But that's what biochemistry is all about pattern recognition.
Correct.
You have to recognize the pattern of the parameters, whether it is hyponatremia with hyperkalemia or hypokalemia with hyperkalemia acidosis. Okay, it's all about pattern recognition. And anyhow, they will mark all abnormal values in red. Okay. Yes, madam.
Yes. Okay, let's go to the first one.
So do you want to volunteer or should we just get it done?
Yeah, because it will take time. But if anybody has got any confusion, please interject in between and let us know why the answer is this, why not this. How can we make our answer? How can we answer this more quickly? Okay, please jump in.
So the good part about biochemistry is often they will mark you, highlight the points that you want to note will be there. Okay, but as Guru said, you should make a pattern and look at the numbers which you think can link to the pattern. For instance, if I see a high phosphorus, I will want to link it to the potassium. So I have to go back and see that potassium, why is it not marked red? Is it normal? Is it low? Okay, so that is what the whole trick is, that you have to first see only the red marks, get those red marks, make a pattern. And now for your differential diagnosis to break down that, look at the other mark, black ones or normal ones to see that this cannot be it, this cannot be it. That is how it works. Yeah, biochemistry, usually they will give you 7 to 8 questions only. They will not cross that. So you get good 1.5 minutes. But be quick in your calculations. You should not waste time in calculating. So if you feel that there is something which requires a huge calculation, skip it. Come back later. Okay. You will not need to read the vignette again anyway. You just need to do the calculations when you come back. Okay. So you can do that.
So that's what here the bicarb is low. So you know that it's a metabolic acidosis. So the next step will always be the anion gap. So 125 is this 139 minus 125. So it is around 14. Okay, 14 means high anion gap. So anion gap metabolic acidosis. That is over. Then actually next is they have shown urea is high, but creatinine is normal. So now the next pattern is high urea creatinine ratio. So for high urea creatinine ratio, these are the causes.
So usually a huge volume depletion, GI bleed as the most common causes. Other could be any sepsis, steroid therapy.
Steroid therapy, yeah.
Guru, you're going on? Guru, are you continuing?
No, madam. You continue.
So a 28-year-old male brought to the ED, unconscious, found in a car with engine running and a hose conducting exhaust into the car, empty bottle of diazepam, empty bottle of whiskey. The following gases are there. Now, he's caught inside a car which has a engine running. Okay. This itself gives you a hint. Okay. Then when you look at the ABG, you look that the saturation is on the co-oximetry is 50, whereas the blood gas which was taken shows the oxygen saturation of 65. So this shows the saturation gap, and which is common in a person who's in a closed area, which allows you to less breathing or with toxin gases. So this goes in favor of carbon monoxide poisoning. Okay, so there is hypoxia, there is respiratory acidosis, and there is saturation gap, which goes for carbon monoxide poisoning. Often for carbon monoxide, you would have burns or a smoked area, or you may have somebody saying that there is a gas geyser in the house. So these also give scenarios which would indicate a carbon monoxide poisoning. A 64-year-old male diabetic with vasculopathy undergoes an attempted endovascular repair for the abdominal aortic aneurysm. However, it is abandoned due to technical difficulties, and he undergoes a surgical repair. In the first 6 hours, he is noted to be oliguric, and the blood test reveals a creatinine of 0.24, which has increased from the pre-op level of 0.15. Now, again, if you see, the potassium is high, chloride is high, creatinine, urea, all the parameters which they have said is mainly high, except for the calcium, which is going towards the lower end. Albumin obviously is lower, high LDH, and even the LFTs are deranged.
Rhabdomyolysis.
Yes, yes.
The most important thing is that as the muscle is damaged, the LDH is also increasing and the AST is also increasing. There are many of you answered the liver failure. So you have to read all these things in context of what's given on the left side of the panel. So by general rule, if there is a low calcium, high potassium, think of rhabdomyolysis. If there is low calcium, high uric acid, think of tumor lysis syndrome. No need to read anything else.
And if they ask you any three, you can tell generalized.
Yeah.
If they ask you list any three likely causes, then you can generalize your answer. But if they say list 3 likely causes, then it should be in this case only. Okay.
Reperfusion syndrome, how can it be ruled out, sir?
Reperfusions.
You need not to
Because
rule
of
out in the
clamping,
exam. You need not to
clamping
rule.
and unclamping.
Why are you worried in the CBS to ruling out? You have to say what are the likely cause. They are not asking you what is the cause of reperfusion. If you say reperfusion, that's fine.
Oh, okay.
You have to save time. You have to pick up the subtle thing. For example, I give you some of you please try to answer this. If a patient in the vignette, they mentioned the temperature of 34 degrees, say 33 degrees Celsius, and the total cholesterol is high. What would be your answer? You need not to, yes, you need not to read the whole vignette. Similarly, if the patient has got AKI, high total protein and some back pain, what will be your answer?
Myeloma.
Right. If there is low sodium, low hemoglobin, some non-anion gap metabolic acidosis, irrespective of sodium potassium, what will be your answer? Addison's disease. If they give hyponatremia, hyperkalemia, hypoglycemia, then it's like it's your luck. You're lucky. Okay, next
So
one.
as Saikat says, it is mainly practice, and I wish that all of you should go through few books like Carol Foote, Bala Venkatesh, because they are very classical books where those patterns are there, and Crit IQ or something like that.
Yep. Next question. Yeah.
32-year-old female admitted to the ward with severe anorexia, mild diarrheal disease. She's hydrated with IV dextrose, NG feeds. On day 2, she's collapsed in the toilet with a BP of 75/45. Atrial fibrillation with a fast ventricular rate of 135, generalized weakness. Her electrolytes are as follows. Her potassium is significantly low, if you can see. Phosphate is significantly low. In fact, everything is low. The glucose is slightly higher than normal, and there is significant acidosis with the metabolic acidosis with the respiratory compensation, which is inadequate. So this goes in favor of a refeeding syndrome. All the things are low except for hyperchloremia slightly, respiratory alkalosis, hyperglycemia, which is refeeding syndrome, which happens because when there is abrupt increase in the glucose levels, once we restart feeding these starving patients, then the electrolytes, because of the insulin, tend to enter in the cells, which causes a drop in the potassium phosphate, which is responsible for most of the calamities or even cardiac arrest, which can happen in these patients. 56-year-old male, 1 month history of weight loss, shortness of breath. Here we have hemoglobin of 12.8, WBC count normal, platelets are significantly low. PT-INR is deranged, INR is 2, APTT is deranged. Looking at the liver functions, bilirubin is raised, proteins and albumin are acceptable, total protein though is a little low. ALT, alkaline phosphatase, gamma, GGT, ferritin is significantly high, iron is normal, transferrin is normal. This, if you look at the bicytopenia, okay, there are 2 cells which are in the lower normal range. So this is going in the favor of HLH. A long history with bicytopenia with a very high ferritin levels goes in favor of HLH. Okay, it could be any cause. It could be autoimmune causes, immune deficiencies, rheumatological causes, or infective causes, or malignant causes for it. 55-year-old known smoker with bronchitis, cough, fever, breathlessness, ceftazidime 1 gram TDS, clinical improvement over the next 2 days. Sputum culture arrived 48 hours later, which shows Pseudomonas, which is only intermediate sensitivity for ceftazidime. So they have clearly said that there is a clinical improvement which has happened over the last 2 days. They have not given you any other antibiotic to judge whether that is sensitive or not sensitive. You have started ceftazidime, which is now intermediate sensitivity. So you now need to optimize the pharmacokinetics of this drug so that the MICs are reached and it can be more effective. Okay, or there could be a cure to this infection. So the best way you can do that is by doubling the dose. And other point which we could have added to this is to give it as an infusion, which will help us to maintain the pharmacokinetics or to maintain the drug levels above the MIC levels. A 45-year-old in the ICU since the last 7 days is back for the traumatic brain injury. A low GCS, now has fever, increased WBC, purulent secretions. What are the treatment options? We have VAP here, which are with Acinetobacter with the colony count, which is significant. Don't forget to look at the colony count because that will give you a huge, I mean, sometimes if it is low, then that is not the cause of infection and you need not treat it. The treatment, it is sensitive only to tetracyclines, colistin, polymyxin, and the treatment is to combine both or may also indicate giving a sulbactam as a sole drug. And do not forget, whenever you have a VAP, do not forget to add inhaled antibiotics to it. So the treatment would be giving either polymyxins with or without minocycline or sulbactam and inhaled antibiotics.
Okay. Meropenem with the colistin will do, madam?
No, because meropenem per se is not very effective for Acinetobacter, and this combination of combine the two when meropenem is resistance has not found to be that effective. Okay, you should not put your foot into marginally right answers. Okay.
Read about the vancomycin resistance, all those things they may ask. So in Western country, you have to understand this Acinetobacter burden is not very high. So what the burden are high? MRSA. So read in and out about MRSA. They can have VRE. Read about VRE. Read about the simple stuff. They will give you a Pseudomonas. They can ask about a ESBL organism. So expect antivigram in and around this or any fungal infection. These are very common in the Western world.
Okay.
A 30-year-old male, previously fit and well, 3 days history of breathlessness, chest pain, muscle pains, joint pains, tachycardia, tachypnea, fever, borderline BP of 90/50. Initially resuscitated with fluids and started on noradrenaline. Blood cultures are awaited. Viral panel in the respiratory swab is negative. His blood results are as follows. Okay, his hemoglobin is fine, a little low. Actually, all trial lineages are on the lower side with the neutrophils of 1,500 only. Sodium 135. The blood parameters look quite okay with a slightly raised creatinine, a high CRP, and a little high CK.
What is
multiple? Sorry.
No. Sorry.
You can see multiple kind of cavitatory lesions, and there is clear-cut history which says that this symptoms are arising from causing multi-organ involvement. There is muscle pain, there are joint pains, okay, and the viral parameters left out. So probably these multiple cavities are very classically seen in staph infections. We also saw in the images section, the staph endocarditis causing kind of cavitatory lesions. So this kind of pneumonia is quite seen in staph infections. And leukopenia with a raised CRP, AKI and all point to it. And the treatment would be to either give linezolid, preferably if it is a MRSA. Clindamycin also can be done, and rifampicin and IVIG is considered in cases of severe staph aureus pneumonias.
Yeah, so basically here the main trick is that in the vignette, you have to remember the Panton Valentine Leucine staph aureus pneumonia causes necrotizing pneumonia. So in the CT scan, you can see the necrotizing thing. Second thing is that it causes severe muscle damage. That's why the CK is raised and it causes multi-organ failure. So this will give clue. You need not to read the full vignette. If you see multi-organ failure type picture, image showing some necrotizing features, muscle damage is prominent, you can say it is PVL, staph aureus pneumonia or necrotizing pneumonia. And the treatment, it's like the standard treatment.
This is not easy, doctor, because we have vignette, we have image, we have labs, and only 1 minute. What to do?
It will be 1.5 minutes in the main exam. So in main exam, you will get 7 biochemistry, if I'm not wrong, or 8. So you will be saving more time, but you have to pick up the main thing from the vignette.
So if like this big vignette or congested slide,
it will be much bigger. It will be much bigger.
Sampath, you want to add anything?
Yeah, whatever I have observed, especially biochemistry vignette, by scenarios, they're very lengthy. Most of the time, the answer lies within the question. You need to pick up those one-liner, and you don't have to, go in detail about the scenario because time is very short. You need to pick up those one-liner answer within the line, like rhabdomyolysis, tumor lysis, specific mixed edema, adrenal crisis. So some of you, whatever observed is there. Apart from reading the questions, when they ask you specifically the answer, you go to specific answer rather than again describing the scenario and then coming back to the answer. So you will not waste time. Biochemistry questions are very tricky. You will either get full marks or will not get any marks. It's like a mathematics. So you need to pick up those lines, and most of the time, it is answer lies within your question.
Absolutely. That is what I said. Actually, biochemistry is the easiest of all because they give you some hint in the vignette. Just read the vignette and it gives you that thing ki ye kya ho sakta hai. It gives that single, you just have to catch that point. What I usually find tough in CPS is loops and curves because I don't know what they are trying to say. They just go zigzag and with some numbers. So they are actually more difficult because there the hint is much, they just say it is shock. Ab kaun sa shock hai, you have to, get those numbers in place, fit into a figure and do it. So comparatively, biochemistry, don't be worried about it's really difficult. In fact, biochemistry in the end, you'll also say that it was the simplest.
And in biochemistry, we should read the question before the vignette or...
So I will say, read the red thing. They will be pointing out which are abnormal result. Read the last line, what they are asking you. If they are saying, what is the diagnosis? Be straight out. The diagnosis is pneumonia. No need to say, patient has septic shock, patient has got multi-organ failure. If they say, interpret, please interpret hyponatremia, hypokalemia, whatever. Other thing, what I have noted, during exam, you people mention metabolic acidosis. You will not get any marks if you don't mention high NN gap or low NN gap. Non-NN gap. There can be low NN gap acidosis. So you have to mention high or non or low, whatever. Low NN gap can also be seen. So no marks if you only say metabolic acidosis. Because this exam is like someone after this will become consultant in their country. So you have to think like consultant. You have to assemble, you have to pick up the important thing, assemble the information and deliver.
Good.
58-year-old subarachnoid hemorrhage 10 days later. Now I know it is a brain thing. Patient has become polyuric. Two things, either diabetes insipidus or cerebral salt wasting. Look at the osmolarity, look at the sodium, and it gives me the answer. It is cerebral salt wasting.
Yeah. Now, one thing some of you answered SIADH. So in the vignette, they have mentioned polyuric. In SIADH, the urine output is low. low. You can't see polyuria in cerebral salt wasting. You can never.
In
We
SID,
have
you
like,
cannot see a polyuria.
yeah, you can't see polyuria. We have got like 876 SH patient in our ICU. They either develop CSW and dumping urine like 300 to 400, or they develop SIDH where their urine output is like 30, 20, 10, something like that. So in the vignette, some brain issue that will point, okay, it could be CSW or it could be SIDH. Then polyuria. No need to read anything. Reading this thing, brain, polyuria, CSW. No need to read the osmolality. Yeah, you can have a look. So
It can be diabetes insipidus. Why brain polyuria can't be DI?
sodium.
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 We need to look at the sodium and the osmolarity to come to a diagnosis.
Yeah, I mean telling that it is reflecting that the sodium is low and the patient is polyuric and brain, CSW. So you say by answering the thing, another 30 seconds, which you can utilize for the next question.
And also urea creatinine ratio.
Yeah, you can see, but just saving time is evident from here, hyponatremia, polyuria, brain. If hypernatremia, polyuria, brain, think of DI. Madam is exactly right, but here the question is hyponatremia, that's why. Any confusion till now?
The last question. Alcoholic, 3 days history of nausea, vomiting. He is confused, heart rate of 130 per minute, other vital functions are normal, gender. Okay. Now admit the ABG and what are the possible causes. So the pH is 7.432. If you look at it, it grossly looks like a very normal ABG. But even if you get a normal ABG and if they've asked you to interpret the ABG, please look at the anion gap. Okay. Now, if you look at the anion gap, the chloride is significantly low. And if you calculate the anion gap, it comes as a high anion gap metabolic acidosis. Okay. And because of this hypochloremia, there is a metabolic alkalosis which is adding to it. And that is what is causing the pH to come back to normal. So there's a combination of high anion gap metabolic acidosis with a metabolic alkalosis because of the hypochloridemia. Okay. And the causes could be either because of liver failure or renal failure. Poisons, ethynyl glycol can cause this kind of a scenario, or a ketosis.
I will give a short thing. I use a Stewart approach. Approaching this, it's an easy thing, 2 minutes. So this has got metabolic alkalosis as well. If you subtract sodium from chloride, the difference is like 52 or 62. 62 is, so the difference should be around 36 to 38, sodium minus chloride. If it is more than that, there is metabolic alkalosis. If it is less than that, there is hyperchloremic acidosis. Here, if you see, if you subtract sodium from chloride, it is 62. So there is some underlying metabolic alkalosis. Now, second thing, for EDIC exam, remember gold mark formula for acidosis. G for glycols, O for oxyproline, L for L-lactate, D for D-lactate, M for methanol, A for aspirin. Now, aspirin is more common in USA, not common in Western, in Europe. R for renal, K for ketone. Your every answer will be heading here. Now you can see the calcium is low. If calcium is low, then the phosphate is high. Where you can see in AKI. So the renal failure could be one cause for this this acidosis. There is ketone positive ketosis. The other could be poisoning. So just looking into the values, you can answer what could be the possible reason for this type of presentation. Maybe we can just show the answer to them.
Saikat, I mean, this kind of Stewart approach, we need to do when apparently the ABG looks normal, right?
No, Stewart approach you can use for any ABG.
But in that case, only we'll get, I mean, either metabolic acidosis or
everything.
alcohol.
In that, if you apply the Stewart approach, you will get everything. So as your time constant, I'm not going into that. I use Stewart approach in and out by the bedside. I don't use the conventional one. Conventional one is for exam purpose, the theory, written, all those stuff. But Stewart approach, it will take it only 2 minutes. There are only 3 steps. Once I discussed in the group long back. 3 steps, will give you answer. You need to save time. You have only got 1.5 minutes. In that 1.5 minutes, you have to come out whether patient has got high iron gap, underlying metabolic alkalosis, respiratory acidosis. Don't miss it, because they will be pointing for everything. If you miss something, they will not give you the point. And gold mark, you can Google gold mark for acidosis. No need to remember cat mud piles and all those, the different thing. Gold mark, that's all. And check the calcium. If calcium is low, phosphate is high, indirectly that means patient has got AKI. Okay?
Okay.
Any confusion?
No.
We'll go ahead. Yeah.
For
Yes.
these toxins like ethylene, glycol, all these alcohol toxins, how to approach? Any trick, any differential?
So in
Dr. Almeri, for ethylene glycol, okay, there will be a lactate gap. Okay, the measured lactate on the ABG and what is done in the lab, there is a lactate gap. 1. Then hypocalcemia will be there. 2. Then this one, osmolar gap will be there. 3. Then they may show you an slide of oxalate crystals. 4. Okay.
Okay.
For ethylene glycol, just look at the lactate gap. Lactate gap is very common. Okay, what is measured on ABG, and there will be a huge difference.
And the one thing they will mention, the patient is some complex psychiatric and has taken antifungal. With 2-9 and what Dr. Guru has mentioned, put it together, assemble ethylene glycol.
Antifreeze.
Any ophthalmic signs, then it is methanol. Okay, including this one.
We'll start with the long cases.
Yeah.
Yes, madam.
Dr. Guru, you want to go?
No.
Guru is keeping it mute.
Okay, so everybody will be know the vignette. They will have the first. So we should directly go into the questions.
Just to revise, I'll quickly revise it because it's not so easy to remember. 55-year-old, unmarried, 96 kgs, brought from home alone. He was in a drowsy state where he was seen with after his neighbors had not seen him for the last 48 hours. Diabetic on metformin, celiac disease on gluten-free diet, depression on amitriptyline and escitalopram. Previous history of splenectomy 10 years ago after a motor vehicle accident. Cervical arthrodesis 7 years back. Allergic to rock and succinylcholine. He can maintain his airway, but his saturation is 92% on 15 liters. There is decreased air entry on the right lower zone. Tachycardic, hypotensive, warm peripheries, GCS of E2, M4, V2, drowsy. Pupils equal reacting, mildly increased tone in both lower limbs with downgoing planters. High temperature 39.5. ABG with the acidosis. Bicarb of 13, lactate of 4.2. There's a CO2 is also significantly high as compared to the bicarb. Electrolytes look fine except for the chloride, which is 116, and a very high sugar level of 45.5 millimoles per liter. High counts 15.1, urea creatinine raise, CRP of 51. Rest other enzymes good, grossly okay. Next slide is showing the ECG and the CT scan. 2 CT scans. And here we come to the questions. You want to take it forward, second?
Can you go to the vignette? I'll go to the vignette. So in the vignette, most of the answers are hidden. So you can see there is some query overdose. Patient is splenectomized. So query some infection, brain, could be lungs, reduced conscious state. There could be some. So the initial 10 minutes which you are getting, you have to be very mindful, write it down, the important thing. Patient has got some cervical problem. So the question can be diverted towards difficult intubation. Patient is allergic to something. They can ask how to overcome this allergy. Patient has got, is an immunosuppressed patient, drowsy state, likely aspirated, And in the gas, ma'am, can you go down? Before that, in the neuro, we can see there are features of increased tone in the lower limb, which can say, and the patient is on some SSRI, whether there is some serotonin syndrome going on or not. This type of overdose and presentation is very common in Western countries. So you have to go step by step, pick up the important thing. In the neuro, they are mentioning increased tone that you can see in serotonin syndrome. However, they have not mentioned about clonus. So serotonin syndrome should come in your differential diagnosis. Patient has got slightly dilated pupil. I will not say very much dilated, 3, non-reactive, which is also can be seen in serotonin syndrome. Patient is febrile, which can also give some point patient could have serotonin syndrome. So serotonin syndrome will be one of the diagnoses. Polypharmacy overdose. We don't know whether patient has taken only amitriptyline or only escitalopram or both. We don't know from this vignette. Ma'am, can you please scroll down a little bit? When they are giving a gas with glucose of high, please calculate the corrected sodium. That's why the 10-minute is very crucial. Again, in the blood, you can say counts are high, some organ dysfunction, CRPI. So some infection is brewing in his body. So a septic shock sepsis picture will come into role. Can you please go down, ma'am? ECG, please. In the ECG, which is striking, the lead AVR, prominent ROF, that point toward the patient might have taken amitriptyline too many tablets, likely TC overdose. So here, while if they ask what should be my management, we should think of giving some antidote for TC overdose. Now, most of you has mentioned the brain is abnormal. The brain is absolutely normal. There is nothing. I have not given the cut of the lateral ventricle, but a little below. Ma'am, can you please scroll down? CT chest is quite apparent. There could be some aspiration, could be cap, could be anything. But in this context, patient being drowsy, the aspiration pneumonia is more common. So what is our provision? What is your provisional diagnosis? Polypharmacy overdose, aspiration pneumonitis, septic shock, AKI, DKA, meningoencephalitis, serotonin syndrome. Interpret the gas, the ABG. There will be high anion gap. There could be non-anion gap. There is respiratory acidosis, lactic acidosis, hypernatremia. If you do the correction with the millimole, I am used to millimole, they will be giving the value in milligram. Then you can calculate. So in millimole, I know the formula. What is the sodium? You have to, what the glucose? You have to subtract 5.5 divided by 5.5 into 1.6. So the correction value will be 12. So if you have calculated the corrected sodium, then from the ABG, you can say the patient has got hypernatremia. That's why the 10-minute is very crucial. Don't miss out hypoxia. That also come in the ABG. Don't miss out respiratory acidosis. That also come in ABG. Interpret ECG, sinus tachycardia, white QRS, dominant R, absent POF, extreme axis deviation. Because in both lead 1 and lead 2, they are negative. So is the extreme axis. Interpret CT scan, normal CT and features of aspiration pneumonitis in the right side. What could be the cause? Could be overdose. Serotonin syndrome can cause low GCS. Sometimes it can cause what is that called? Agitation as well. Meningoencephalitis could be one possibility. Metabolic encephalopathy, you can say the patient has got AKI, respiratory metabolic, and septic encephalopathy. What investigation in Western world? What is said? We send toxicology panel. We don't send TCA. Many of you has answered about the TCA level. We don't send TCA. It's not available, or if it's available, it's very costly. What we send? Blood alcohol, salicylate, paracetamol, 2 level, 4 hours apart, and urine drug screen. This is very standard. Don't miss out respiratory swab because the patient has got respiratory symptom. As you know, COVID is now almost an endemic thing. Please mention COVID. If they have in their answer sheet, if they mention about COVID, you will get marks. Urine Legionella, urine streptococcal, anybody coming with cap, aspiration, or not aspiration, cap, we by default, we send urine Legionella and urine streptococcal. It is by default. Blood ketones, patient is ketotic, patient is having decay. We will check blood ketones. Blood ketones is easily available, is a point of care testing in Western world. Bedside focus nowadays, more and more stress on doing the bedside focus. Just carry the machine and chuck the probe and see what's going on. Serum osmolality, yes, why not? We need to rule out the osmolar gap. We need to rule out whether it is a honk or decay. So this is all in the context of what patient has got. Lumbar puncture, yes. Is there any contraindication from the vignette? No, platelets are fine. INR is not that high. So lumbar puncture, yes. How? And already we have done the CT scan and it is normal. How do you manage? I'll secure the airway. Patient is 39.5. You have to cool the patient. You have to use paracetamol. If not control, you have to resort to other cooling measure because with that high temperature, patient may go into rhabdomyolysis. Nobody has mentioned we have to cool. It's you will be doing when the patient is having 39, which is like a temperature of 104, 105 degrees Celsius Fahrenheit. You will be giving something to cool him down. Resuscitate, vasopressors, access. Don't forget to mention about access, arterial line. You have to see in the vignette whether they have mentioned whether they have plumbed in the lines or not. If they have not, then it's your duty to plumb in the central venous line. Like when we are in duty and the patient is sick in ED, we go. If ED is busy, we just go and just plumb in the line in the patient. That's how it works in the Western country. Of course, you have to start insulin infusion and with concomitant potassium correction, because if the potassium is below 3.3, you can start insulin infusion in decay. Here, potassium is around 3.8, 3.9. If you start that high dose of insulin, 0.1, the potassium will go inside the cell and the patient have arrhythmia with that arrhythmic abnormal ECG. Bicarbonate bolus, you have to give antibiotic after with full septic screen. If what are your concerns? The patient has got this cervical arthrodesis, so it will be a difficult intubation, limited neck mobility, low apnea time because all critically ill patients have got less oxygen reserve. It is a critical intubation because the patient is acidotic. So when you will be intubating such patient, you have to match the patient minute ventilation that you people, every one of us do by the bedside for any sick acidotic patient. If you don't match the minute ventilation, once you intubate, the patient will crash in front of your eyes and the patient is obese. So how will you intubate? What we do, we just give a call to anesthetics. In case if it's a difficult intubation, as we know is anticipated difficult intubation, they can help, and they are quite sleek because they are we all, maybe most of us are from anesthetic background, but these anesthetic people are doing this difficult intubation in and out in the theater. So in Western country, give a call to anesthetics. Hey guys, we are intubating a difficult patient. If required, we'll give a call. Please come. So anesthetic standby, hyperventilate with bag marks. I mentioned why. Video laryngoscope is easily available in Western countries, CMAC, because it will help to restrict the neck movement. As the patient is allergic to rock or and succinylcholine, we can use cisatracurium because there is less cross reactivity in patient with rocuronium allergy. Now, what will be an antibiotic? We're thinking of meningoencephalitis, so we have to use a meningitic dose of antibiotic as per the European guideline, not as per your local guideline. So the most commonly they use a ceftriaxone, 2 gram BD, vancomycin loading because of the streptococcal, what is it called? Drug-resistant streptococcal. Benzyl penicillin is the first choice for listeria in Western world. You can say ampicillin, that's okay. Better to mention both, and dexamethasone. Right? Any confusion till now? Is there anything anyone wants to clarify? Before we move.
During workup, we can mention like toxin screenings. Workup, it will be enough, or we should mention everything?
No, just mention urine drug screen and toxicology panel. So when a patient come here with overdose, we get to see a overdose patient. We don't know what different type of overdose. So by dictum, automatically, even before we say the ED consultant or ED physician, they send the toxicology panel, and automatically they give a call to toxicology on call. So these are very common. Yes, if they say what type of services will you use, we'll give a call to Tox. We have got a dedicated web service, not here in any Western country, even in US, Europe, UK, Australia, Singapore, web-based service, or we'll give a call to the toxicology on call. We have to give a call. It is a medical legal thing. Even if we know how to manage, we need to involve them. So the next vignette, patient was resuscitated with 2-liter fluid, started on NORAD after securing access, arterial line, anesthetics were involved, pre-oxygenated, intubated with C-cyclophentenyl ketamine, on ventilation, started on meningitic dose of antibiotic, kept sedated, lumbar puncture performed, report awaited, insulin started, potassium correction done. Few reports are back from the blood osmolality. We can say now patient is into decay, not honk. In honk or HHS, the blood osmolality will be more than 320 or 330, at least more than 320. So that's why serum osmolality in context of decay is very important to include in your initial workup. And also it will help you to calculate osmolar gap. You need not to calculate osmolar gap there. They will say in somewhere in the variant, osmolar gap is normal. Urine Legionella are negative, urine streptococcal is pending. So now is a gas. Let's go to the questions, or maybe there is a echo.
So in this actually, because nobody corrected the sodium in the first minute, everybody said honk. And many questions had to be skipped. I skipped many questions in the next, in the same minute for this reason, because nobody came up with the answer that it is actually DK, not honk. So in the further panel, further questions, actually there are many questions which come specific to DK. We skipped that, at least I skipped that question when I asked the candidates. So you have to correct the sodium when it comes to glucose.
Yeah, that's what we do by the bedside, because if we don't correct sodium, what will be? We will be rapidly correcting the sodium. That can cause problem to the brain. If it's acute, if in decay, you can rapidly correct sodium, but if it is HHAs, you can't rapidly correct sodium. That's the thing. So it's very important when you are getting high glucose, calculate the corrected sodium for the patient. So there is a echo clip where you can see that right heart is collapsed. So the features of, some of the features of underfilled heart is kissing sign, the left ventricle is collapsing, the right heart is collapsing. So the next question is based on what you can see in the echo. The classical thing, what do we do? What we can see by the bedside echo. Right heart collapsing, papillary muscle, hyperdynamic heart, because it's a septic shock. Some sepsis is brewing in the body. So the heart is hyperdynamic and underfilled. Then how do you manage as the sodium is already high? When the sodium crosses 155 marks in most of the Western literature, the dictum is that you have to start half saline. Even suppose in my unit, if I don't start, the nurses will be after me and they will directly give a call to the endocrine. Hey, the intensivist is not starting this. The chain works like this. They will be calculating. Even if I'm not calculating, they will be collecting, hey doc, this is a corrected sodium. We can't correct it too fast.
Anion gap also should be calculated after correction or before?
If albumin is given, yes.
No sodium.
You are asking about the anion gap, right? Anion gap is corrected for, yeah, right. So I think, yes, you should.
After correction.
Correction, yes. You should do, because if before correction is high, after correction is automatically high. So it's like wasting time. How do you manage this fluid? Change the fluid, because if you do the correction with that glucose, the sodium is already more than 155. And the main role in decay management, you have to close anion gap with fluid. Typically, we give in decay like 4 or 5 liters, and in HHS, we'll end up giving in 6 to 8 liters. Potassium correction, and when the BSL is around 200 milligram or around 15 millimole, we start 5% dextrose, because we don't want a rapid drop in glucose, because it can cause cerebral disequilibrium, and also these 5% of glucose also gives some amount of energy to the patient and prevent a ketosis. Now, the next question is that where we should not use this high fluid resuscitation, mainly in young, because of the cerebral edema, in elderly patient because they have got too many comorbidities, fluid overload, hepatic and renal failure patient because of fluid overload, in pregnant patient because of they have already leaky capillaries, they can lead to cerebral edema. What are the target? This is as per the Joint British Diabetes Societies. 0.5 millimole per liter per hour. You have to say the unit. It's not 0.5 millimole per liter per hour. Rate of rise in bicarbonate is 3 millimole per hour. Rate of fall in glucose is 3 millimole per liter per hour. So you have to mention everything. So for bicarb and glucose, it will be millimole per liter per hour. Disadvantage and advantages, most of you have answered this one. Nothing, hyperchloremia, cheap and available. So it's the advantage. The disadvantage, it is hyperchloremic, chloride load. It plays with the tubular feedback, predisposes to AKI, and it causes non-anion gap acidosis. What are the main differences in fluid and insulin regimen? Most of you have answered. The fluid resuscitation is a bit slower because they are at risk of the cerebral edema, and insulin regimen is a bit slower. Next vignette. Next question, please. So now he remained on NORAD, 2 liters of resuscitation. Ambulance crew informed that he most probably has his TCA overdose. Some of the blood reports are back where we have mentioned osmolar gap is normal. So you know those toxin which causes high osmolar gap is automatically ruled out. Urine streptococcal antigen is now negative. It doesn't mean if the patient has got streptococcal pneumonia, that patient need to have positive urine streptococcal antigen. Just to divert your attention. Again, you can see the sodium is going up. You have to correct the sodium. You have to calculate a corrected sodium, but with the 20 or 22, the corrected sodium will be like 4 or 3. So you can mathematically say the corrected sodium is around 153 or 154. Can you go to the questions? So what are your management priorities? Now you know the ambulance crew mentioned the patient has got TC overdose. So we have to manage the TC overdose here. We have to chase the pending report, and we have to target slow fall of sodium and continue the decay management as per your hospital protocol. This question has been asked in previous edict. What sources or which information sources do you use when dealing with overdose patients? Toxicology info service, ToxVex, or any wave similar wave platform, and we'll contact a clinical toxicologist. Mechanism of TCA toxicity, you have to read. Nothing to say, sodium channel, alpha blocker, alpha-1 blockade, anticholinergic, antihistaminic, and GABA antagonism. Most of you have answered only 2, sodium channel and anticholinergic, but you failed to answer the second, third, and fourth. So implication of the QRS, you can see more than 100, they have got 33% risk of seizures, more than 160, they have got increased risk of VT. How do you manage soda bicarb bolus? There is no role of soda bicarb infusion in managing TC overdose. In TC overdose, you can use bicarb to crank up the pH to 7.5 to 7.55, but it is mainly by hyperventilation we maintain the pH between 7.5 to 7.55. Treat seizures and arrhythmia, fluid management, vasopressors for the blood. Of course, is any role of soda bicarbonate infusion? No, absolutely no. Only bolus dose has got role. Next we need. Now, most of you have answered is VT. Patient is in polymorphic VT. What would you do first? You will start CPR. Nobody has answered, you will start CPR. If the patient having VT, it's not mentioned the patient has got a pulse or not. We will consider the patient has no pulse here. You will start CPR. You have to mention I will start CPR as per protocol. Then optimize electrolyte, and this VT is mainly because of the TC overdose, keep bicarbolases. Other thing you can consider hypertonic saline, lignocaine, intralipid, ECMO, and all those stuff. 3 arrhythmics, procainamide, beta blocker, and amiodarone or flecainide should be avoided because they interfere with the sodium channel blockade. Next, he reverted to sinus rhythm. On day 2, he remained on smidge of NORAD, and his end organ perfusion improved. LP report suggestive of he has grown Streptococcus pneumoniae. Can I go to the questions? So this is the classical thing where we will perform CT, but here already we have done the CT. Papilledema, immunocompromised state, altered level of consciousness, focal neurological sign, new onset seizure, where we'll be performing CT before doing the lumbar puncture. Here it is likely pneumococcal. So what factors has led to these condition for hip in this context? He is old, he is frail, he has no spleen, he is immunocompromised. That's all. Role of adjunctive steroid, most of you have answered, mortality and neurological and hearing loss, and have to give before the first dose or along with the first dose. How would you follow up vaccination now and after 5 years? And splenectomy patient, classically we enroll them in the splenectomy, what is that called? Anyway, there is a database for the splenectomy, and they are mainly on lifelong suppression antibiotic with amoxicillin, low dose. So you have to mention these two. Next, we need. So the features, the important thing which I have included is NPI, which I have mentioned once in the group. NPI is a neurological pupillary index. Now it is more validated than the normal pupillary reflex. Please have a read about that. Automated pupillometry. European people are mostly talking about NPI. So all these features suggestive of normal NPI is more than 3. So they will give a value around 2 or 1. It is more reliable than pupillary reflex. What do you suspect? Brain dead. What you would do next? Apnea testing. Then the precondition, the normal thing, most of you have answered. Condition consistent with that, normotension, metabolic cause, intact neuromuscular function, minimum 4 period of observation. You people have answered. Next, what are the indication of ancillary test for brain death? If you can do the apnea test if they have got high spinal cord injury, or at least you can examine at least one eye or 1 ear. Now, if there is a tympanic perforation, that's not a contraindication of performing the cold calorie test. Just remember this. What are the two techniques? 4-vessel angiography or SPECT. There is no role of TCD, no proven role. Now, we have performed apnea test, 2 tests positive. In outside world, we don't follow the 6 hour. So what we do, one intensivist come, they do the first, they write their finding in one of the sheet, and then the next intensivist come in next 5 or 10 minutes, and if we also find the second one is positive, they just mention positive. No need to, it's in India, we follow the 6 hour time interval. And you explain the family about the brain death. The family, we are maybe the up, we have to go up. Please scroll up. Can you scroll up? Yeah, the family notices the patient is sometime moving his right arm, and they question about the diagnosis of your brain death. So it is a spinal reflex, like maybe Lazarus sign. So you have to say this does not preclude a patient from having a brain death. So brain death for patient, they may not understand what is brain death or circulatory death. You have to say patient has died. It means brain death. We know what is brain death. Family may not understand. If they ask, you have to say patient has died. Then the niece of the patient is concerned if the patient is dead, why the heart is beating, and why the hand is still warm, because the circulation is maintained in automatic manner. His heart doesn't depend on the brain to function. Once we disconnect the patient from the ventilator, the oxygen supply will go down and automatically the heart will stop beating. As now we are giving oxygen to the ventilator and the patient heart is beating, so his peripheries are warm. That's how you will counsel the patient family. Simple. After the family accepted the condition and counsel for organ donation, whatever they say, you have to say no. You have to respect the patient, the donor, and the program and the organ donation program. You can't reveal. And in donating the human organ, there is no monetary benefit involved, no financial gain. So this part, sometimes they will be asking, like the patient has died, what will you do next? The next thing would be, we'll involve the donation team and we'll discuss about the donation in a non-coercive way. We can't force. So the donation in India is different and donation in Western world is different. By dictum, all patients here are eligible for donation. They can be donated. Is an opt-in. In India is opt-out. Am I right? It is opt-out in India, right, madam?
It's opt-in in India. Why opt-out?
Opt-out is in here. So here,
In
all
India.
are eligible for donation. If they decline, then it is opt-out. Yes. So in India, it is opt-in. Then the family asks the patient has a friend on the list. No. They ask, would we know the recipient? No. Confidentiality. Protection of the donor. Since we are giving his organ some money, no. No financial gain. Next one. So again, this suggestive of diabetes insipidus, central, desmopressin, free water, monitor sodium. And anybody has got any questions?
Dr. Sampath, have you left? He wanted to say something, but he had to leave for some emergency. Okay.
That's okay.
I asked
Anybody has got any questions? Before I
the
move
most
to the last
important
one.
thing, actually, from this whole case, I would say one thing, what Dr. Sekat said in the beginning. When you get the first vignette, you have to actually analyze it and start forming what could be the further questions. That is how you can save time in the whole case. That 10-12 minutes that you're going to get that first vignette, take your time, see what can come, like small things, splenectomy, a cervical fixation, so immobile neck, allergies, all these things should be just etched in your mind and you should make a small case of scenario ki ye kya hai. Okay, and calculations about looking at correction factors, all this has to be done and you need to have a diagnosis. I mean, even after giving the vignette for 10 minutes and if you say it is not a DK but a honk, then it becomes gross that 10 minutes you didn't analyze the ABG. Right? So very important factor is you really have to give time to that first vignette. You have to say something, Guru?
No, madam. No, madam. Just.
So first vignette should give you points, should give you everything. First
Just one thing.
Half the story is known ki wo kya पूछने वाला hai.
Just Saikat, we have to confirm about that anion gap, what Dr. Almeri asked, with whether you use a corrected sodium or the sodium which comes. I think once this discussion had happened, I would take the sodium which is given for anion gap, not the corrected sodium.
Okay, fair enough. That would be fine.
But Srinivas sir had responded with the corrected sodium.
No,
so I am not.
correct sodium only. Why will you not correct the sodium?
No, for the anion gap calculation.
No, you have to use the corrected sodium.
No, madam. I'll share you the article because the chloride and whatever happens, the thing, it doesn't match with the corrected sodium. I'll share you an article about that.
Okay, fair enough
Yeah,
for the anion gap. Go with the normal thing, but my understanding, if with the normal sodium, if the anion gap is high, with the corrected itself, it will be high. The only thing which can come into role is the additional metabolic alkalosis. I'm just using my Stewart approach.
I'll share the next one if there are no more
Yeah,
questions.
I think you should start the next one.
that was very good explanation by Saikat about the steward's approach of how you can make, or else in our Boston approach, the traditional approach, if you have to search if you have to see if there is a metabolic alkalosis, then you have to do a delta ratio. Okay. Here he nicely told that normally the strong hand difference is around 38 to 42, because here the strong hand difference was coming around 58 or 60. So obviously there is an metabolic alkalosis. And another thing what you have to see is if there is acidosis, but the bicarb is not that low, then that time also you can think that there is an metabolic alkalosis. If the bicarb is 18, 19, 20, but still the pH is low, then you have to see, you should think that there is an associated metabolic alkalosis. Then other clues like hypoalbuminemia, hypochloremia, they will all contribute for your alkalosis. Hypokalemia.
Yeah, Stewart
Am
approach.
I right, Saikat?
Yeah. Stewart approach is mainly for the ESICM people, or mainly the European people. They love to use the
They
Stewart
try
approach.
to fill in the gap.
Yeah, Stewart approach is the easiest thing because the Boston approach is good, but it's quite cumbersome because you have to do multiple calculations. Sometimes because of the time pressure, we may not be able to calculate everything. So it becomes very easy with the Stewart approach to get the answer and set time. I have used Stewart approach for my exam during a week, and it set time. Hardly it will take 30 seconds.
Even ESISM people expect the same. You use a strong and difference approach.
Yeah,
Stewart
they
approach.
are very much supporter of Stewart approach.
Yeah.
Okay.
So I'll read out the first minute.
Yeah. You maybe you start a show. If anything, I will intervene.
Okay. 57-year-old, 75 kg, known alcohol abuse, illicit drug abuse, presence with severe upper abdominal pain, nausea, vomiting last 24 hours, has been drinking 3 stubbles of beer daily. Maintains his own airway, saturation 91% with 4 liters oxygen, tachypneic, tachycardic, sinus rhythm, BP 88/50, GCS 14, moving all 4 limbs, temperature 38.1, jaundiced, abdomen distended, tender, but not peritonitic on examination. Hemoglobin is a little high, WBC 16,000 higher, platelets 170, urea raised, creatinine raised, bilirubin significantly raised, albumin is acceptable, ALT, alkaline phosphatase are increased, alkaline phosphatase is almost 5 times of the normal value, GGT is raised, INR is acceptable, and CRP is raised. Looking at the ABG, it is a combination of metabolic with respiratory acidosis with slightly high sugar, high lactates of 11.5, and this is the CT abdomen which the gastroenterologist has asked for. Okay, so the CT is showing a blurred margin of the pancreas, which indicates acute pancreatitis and its complications. So multifactorial shock, multi-organ failures, high anion gap acidosis from lactic acidosis, and respiratory acidosis. So the first question often is give the diagnosis and how will you proceed further. So when you read the first minute, that section should be completely ready. CT scan findings, swollen edematous pancreas and non-enhanced areas of necrosis. Most likely cause, because the liver enzymes are also deranged, it could be most likely acute biliary pancreatitis and associated ascending cholangitis. Immediate treatment priorities is ABC, hemodynamics, fluid resuscitation using the goal-directed approach, early use of vasopressors to maintain the MAP, look for chest X-ray, lung ultrasound, good analgesia, maintain the intra-abdominal pressure. Monitoring and intra-abdominal pressure is a very important thing these days. Early ERCP, since we are thinking of biliary cause for the pancreatitis, since he's alcoholic, high dose thiamine and monitoring for alcohol withdrawal will also be one of the management plans. Other investigations, look at the hepatobiliary system, send all cultures, look for amylase, lipase, other causes of pancreatitis like serum triglyceride, serum calcium also should be a part. The severity of acute pancreatitis, various scores are there, BICEP, which is the most accurate, then CT severity score, Glasgow score, and the Ranson score. How do you monitor the response to fluid resuscitation? Look at the change in the heart rate, maintain a blood, look at the blood pressure target if you're reaching, your hourly urine output, hematocrit decreasing. Is there a role of antibiotics? Yes, there is a role when you are suspecting ascending cholangitis or biliary cause as a cause of the pancreatitis. Yes, there is a role of antibiotics in case of acute pancreatitis. However, if we are looking at only sterile necrotic pancreatitis without evidence of cholangitis, there is no role of giving antibiotics. Then the patient undergoes an emergency ultrasound with a dilated common bile duct. He was transferred to the endoscopy suite for an urgent ERCP. 3 to 4 bile stones were removed and pus was sent for culture. Lipase is 1,600. Triglyceride is 2 millimoles. After the procedure is shifted to the ICU. The chest X-ray on admission is showing bivessel atelectasis and is put on high flow nasal oxygen. Adequately resuscitated with balanced crystalloids for the next 24 hours. Metabolic acidosis improved. Ceftriaxone started because of ascending cholangitis. His pain remains well controlled on PCA, oxycodone. Opioids are being given. On day 3, he's deteriorated again, worsening tachycardia, increased work of breathing, hypoxia, but hemodynamically he's stable. Chest X-ray is repeated, which is shown below. Hemoglobin now is 12. WBC counts are 19. Platelets acceptable. Urea creat is still very high. Bilirubin is acceptable. It has come down. Albumin, ALT, alkaline phosphatase, GGT are all better than before, but the CRP has worsened. Lab confirms that the bile culture is showing a pan-sensitive Klebsiella oxystosa, and a blood culture is not showing any positive signals. Sekat, you'll have to take it from here. I just have to open.
Yeah. So what is the possible reason for its deterioration? It could be bilateral pleural effusion, could be atelectasis from diaphragmatic splinting, acute lung injury because of the pancreatitis, or maybe some hospital acute pneumonia is already 1 or 2 days in ICU. What further thing you would consider at this point? You will clinically assess, you will do a gas, and you will repeat the full septic screen. How will you optimize? Maintain oxygen saturation, NIV trial, anesthesia optimization, physiotherapy. Here we'll be escalating antibiotic because it is likely some extra pancreatic infection. Optimize fluid balance. We'll continue monitoring the intra-abdominal pressure. We have to give attention to his nutrition. And most important, these pancreatitis patients are very, very thrombophilic. We have to start some thromboprophylaxis. Now, what antibiotic, as the patient has deteriorated from the cephalosporin or whatever we have started, will escalate the antibiotic to beta-lactam. What will be your choice? Okay. How will you optimize his nutrition? Just now I have shared one ICM intensive care medicine article on acute pancreatitis. Go through that and read about the trial where I've mentioned by the side in bracket, oral feeding as soon as tolerated. This is Becquerel trial. Is a long done, I think 2013-14. If oral feeding not tolerated, then enteral feeding. There is no role of total parenteral. It is like partial parenteral. This is 2019. What is that? World Society of Emergency Surgeon guideline. Like you have to add partial parenteral nutrition if enteral nutrition is not completely tolerated. Next vignette, on day 4, he was tried on NIV and was requiring a FiO2 of 0.5. In context of continued deterioration, he was intubated uneventfully and started on noradrenaline at 10 mics. He was kept sedated on fentanyl 100 mics and propofol 50. His abdomen was severely distended, which significantly reduced air entry in the lung bases. Soon after intubation, his FiO2 increased further to 0.7 with PEEP of 10. he remained oligoanuric, likely. So this means the patient is going into abdominal compartment syndrome, or there could be some retroperitoneal hemorrhage from where? From splenic artery aneurysm. There could be bile ischemia, or there could be portal vein thrombosis, which is very, very common in pancreatic patient. Then one of you has defined IAP as more than in abdominal compartment syndrome, more than 12. No, the IAP is more than 20 plus new organ dysfunction. Cause overzealous fluid resuscitation, ILS, or associated ascites. What are the consequences of abdominal compartment syndrome? Most of you have answered. You have to go organ-wise: brain, heart, lungs, kidney. I think you people, most of you have answered correctly. How is the abdominal compartment pressure measured? There are two methods, either direct or indirect. You have to directly, the surgeon sometimes introduce the needle into the abdomen directly, or indirect method like through the blood. What are the available options? First thing, we have to maintain the abdominal perfusion pressure by titrating the vasopressor more than 60. Positioning is more important. Analgesia, sedation. We have to optimize fluid balance. The patient is oligoanuric. Likely, we have to start CRT. We have to decompress stomach, drainage if any collection, and if all fail or medical therapy fail, then you have to go for surgical decompression. Now, untreated abdominal compartment syndrome, just remember it is associated with 100% mortality. Like abdominal aortic aneurysm, if not treated, it lead to 100% mortality. Similarly, untreated ACS is associated with 100% mortality. What would you do? We have to repeat the CT with contrast. Now, most important, just keep in mind, patient has got AKI. We will ask our radiology colleague to use a low osmolality or non-ionic radio contrast type. We'll start CRT. We have started feed in the previous vignette. We have to stop the feeding here. We have to continue, keep on monitoring the IAP. Next vignette is that CT abdomen on day 4 showed edematous bowel with features suggestive of paralytic ileus and stable necrotic pancreatitis. His feed was temporarily withheld. Started on CRT. From after a few days, he showed improved trend. The CRT was backed off. Trophic enteral feed resumed and antibiotics stopped. He continued to improve over the coming days and was extubated. Now the trick is day 18, 3 weeks from the initial phase. So you have to be worried about infection. Patient is febrile, septic shock, noradrenaline, CT abdomen done. What you can see in the CT abdomen? Gas locule. So it is infected necrotizing pancreatitis. How will you manage? Here you have to use antibiotic which has got good penetration. Imipenem and cilastatin. Some study has shown imipenem cilastatin is better than meropenem. You can also say meropenem. No wrong. Consider CT guided FNA, septic screen, ABC. Patient has got old line. If any, you have to change. So keep this subtle point in your mind. If the patient has got line or old thing, we have to keep in mind, we have to change all those lines because those could be the needles of infection. And now 2 medical students asked you about the role of procalcitonin. So according to this World Society of Emergency Surgery guideline, if you Google, you will see it's a grade 1B. The serum procalcitonin help in predicting the risk of developing infected pancreatic necrosis. You have to remember, please go through the guideline. What will be your next plan? In this case, keep on discussing with multiple team regarding what is the best treatment for him. Now, this is a new trial. One is the Step Up trial 2012 and the Tension trial, which was published in Lancet. Please read that one. Here, we have to consider for endoscopic or percutaneous drainage. And if you go through the guideline, they have mentioned by doing the endoscopic or percutaneous drainage, they have avoided the need of subsequent necrosectomies in about 30 to 60% cases. Followed by, after this, if required, we can do the endoscopic or video-assisted retroperitoneal debridement. This is as per tension trial. Indication for the surgical intervention, these all mentioned in that guideline as a continuum in step-up approach, abdominal compartment syndrome, acute necrotizing cholecystitis, bowel fistula, acute or ongoing bleed. Would you offer cholecystectomy? Yes, during the same admission. In ERCP biliary pancreatitis, you have to offer cholecystectomy on the same admission. Now, he underwent endoscopic guided drainage, started out imipenem, percutaneous culture growing ESBL E. coli, and he's already on imipenem. No issue with that. He was continued antibiotic for 7 days, improved transition to oral feed. Surgeons offered him laparoscopic cholecystectomy. Might be he's already fatigued or what, he's already frustrated what's going on with him, so he refused. On day 26, he developed diarrhea, stool PCR positive for C. diff. So what are the risk factors in this case, not in general? Beta-lactam, prolonged hospitalization, at least for a month, albumin is low, and the renal impairment. What are the barriers with ongoing diarrhea in this case? Increased risk of pressure source, increased risk of infection, nursing burden, because you have to make 1:1 strict nursing for this patient. Infection control risks to other patients. What are the specific treatment? Oral vancomycin, metronidazole, you can give oral or IV, or fidaxomicin. What are the options available? Subtotal colectomy, fecal microbiota transplant, or monoclonal antibodies are under development. Down. Ma'am, can we scroll down? So what are the infection control? So what I do, isolation, inform the infection control team. We put up the precaution mark. There is a small like precaution alert hanging outside the bed. Full barrier precaution, hand washing with soap and water, not chlorhexidine. And post discharge, you have to disinfect the room. That's all. Anyone has got any queries?
This case was quite straightforward. There was no confusion actually.
Yeah. Anyone has got any queries or any confusion?
Most of them have left. There are 3 left.
That's okay. They got bored.
One question.
Yeah.
So, when you are asking or telling what else, that means I missed some key answer, but nothing to tell what to do in this point.
Yeah. So sometimes some examiner can be really kind. They can ask what else, 1 or twice, but if you're repeatedly missing important thing, they may not ask what else. They will just jump to the next question.
Yeah, that's why I have to play around this point.
Practice. Can't help it.
Being a perfectionist, I would say, don't go on the examiner. Somebody will give you just a blank look, not react at all, even if you are the best. And somebody will keep nodding even if you say wrong.
Yeah, I got one examiner.
Don't trust them.
On his faces was like sitting like this. Whatever I'm saying, I was a bit confused. Am I right or I'm wrong? Just be confident and keep on answering.
Doctor, finally, we will answer what we know. That's all.
Yeah.
Isn't it? What has struck our mind and what we will don't try. Means we should not beat around the bush. Try to be more specific. If you say you don't know, just go ahead. Instead of that machine gun approach or whatever they say. If you are confident, not even if you are near confident, also you can answer. But if you absolutely are blank about the topic, but don't try to proceed, because the next questions, see, like the 5th or 6th vignette is about brain death, which you would have read. Then there may be questions on apnea test, which you can answer. About counseling, you can answer, because there you may get points, isn't it? something which you didn't know, you kept on telling one or the two answers and the examiner didn't proceed. That also should not have. Only thing in CCS, you will not go back to the previous scenario, but still you have got chance of scoring more in the next vignette, which may be a simple thing. Like if the patient has developed abdominal compartment syndrome, next question may be how you will measure the abdominal compartment pressure. So that you may be knowing, so you will get points for that. Basically, you have to be what we say, the conscience should be right, and you should be very straightforward. If you don't know, you straight away say it's, you don't know.
Yeah, so simple thing like arterial line, hemodynamic monitoring in the initial workup, you should not miss. If they have not mentioned in the vignette, they are expecting you should tell. These are very subtle
Best thing is you have to discuss. Means you 2-3 people you sit together and do such mocks or discuss such things. Those very nice books are there. FFICM. Those books they have got that pink and blue book. There are 2 books. And they have given a scenario. Though they are little bit old, but at least the basics remain the same. The advances are different. The basics remain the same. ABC will be ABC, how much ever advances happen. But in those 2 books, if you don't, I think most of you people have that book. I don't know the name of the author. So 2-3 of you sit together and go through that book. And for CBS and all, I think Carol Foote, Bala Venkatesh, Crit IQ, they are all very, very important. Pattern recognition. I'll try to share the data sets which I had got before about pattern recognition. Okay, in the group that may also help. Like it is like if there is hyperkalemia and hyponatremia, there are 4-5 causes. You have to just keep on telling.
I have that, Dr. Guru, you had sent me once. I'll share in the group.
Yeah, you share in the group.
I'll
Okay.
share.
Yeah.
So basically the basic thing, don't forget the lines, when to start CRRT. They expect that we should answer. And like some of you mentioned nephrology referral. No in Western world. CRRT. Nephrologists can't come and intervene in the ICU. They have no role. They say patient is in ICU. We're happy to be involved. But CRRT slate is your part.
They only call the surgeons.
Call the surgeons. Even like it's a very much trust thing. That's see in Western world most of the ICUs are closed. I think even in the Middle East as well. So no normal dialysis CRRT by dictum. In EDIC question, always CRRT.
Correct.
Anything else? Any feedback? After we have given the exam and now we have gone through the answers, maybe we can stop recording now.
No, let the tips go to everybody.
Okay. I would like to ask everyone, what's your feedback?
Let the feedback also go to everybody.
Yeah, feedback is very important.
So how was your feedback? Yes, after giving mock 2, I got many messages on personal which said, I'm totally depressed.
I failed in everything, I think.
So we actually, first mock that we made was quite acceptable, like how the standard should be. Second mock, Sekath wanted to make it very tough. He really grilled the paper so many times to edit it. Nahi, I'll make it more tougher.
And the first 2 cases were from November edic.
Yes.
So I've given my November edic. In the main exam, I passed those cases. And in this
all the 4 cases were from November edic, Samyukta.
I passed all 4 cases in the main exam. In this exam, I failed all the 4 cases.
See, the pass in the main exam is totally different on the ANGOP. If, like suppose if you all have failed in the exam, most probably in the main, after going to the ANGOP, you all will pass.
Amen. That's the only thing I have to say. But yes, it was I have learned one big point. My biggest mistake in long cases was that I didn't read those in those 10 minutes. I just hurried up into giving the exam. So I missed many important things. So for all candidates, those 10 minutes are the make or break time for the long case, because I missed diabetic ketoacidosis, I missed splenectomy. So the whole case was finished at that point only. When I saw the vignette again, I knew I will never be able to make this up. So that's a very
one more thing. I think you will be studying continuously, okay, and then you get mentally tired. Okay, so don't sit idle when you get mentally tired. Just go to the Critilearn website and see the debriefing at least. Means something which you can strengthen your thoughts, what you have to answer, what you may be missing, because that doesn't need much concentration. Going through the debriefing, isn't it? You have seen it once, you have seen it twice. Okay, so don't go and sit somewhere. Instead, you go through the Critilearn website and go through the debriefing.
okay.
Yeah.
I think they also asked in your November edict regarding this endoscopic approach for the pancreatectomy, necrotizing pancreatitis.
I've actually, Dr. Shaikar, absolutely forgotten what they asked me. I'm absolutely blank. I could just recognize 2 cases. But ma'am is saying all 4 are from that. I don't even remember the other 2.
That's okay. But it's more important. Please go. I have shared one acute pancreatitis from the intensive care medicine, which was published this year. Please go through that. Because when they're publishing in the ICM, that means it's important. Anything being published in the ICM in the last 6 months, go through that. You can just trawl through the ICM journal and see what the important topic have published pertaining to our field.
And also go through the discussions that happen in the Critilearn group.
Yeah.
Saikat is regularly putting MCQs and images. They will definitely help.
MRI,
we don't know whether Saikat is an examiner in ESISM also.
He soon will be, Guru. He soon will be.
So there may be some overlap of whatever he has put in the group.
Next, he will be migrating to UK and then being one of the examiners.
The other thing is that they will not ask MRI. Be sure of that. That's fine. Another thing I was going to tell.
Like any basic these stroke MRI or things like that won't also be asked.
I don't think for that you need to read anything.
No, probably in the discussion. Probably in the discussion when it comes to once the thrombolysis has failed and if you have to go for some interventional things. Okay, that time you may have to talk about perfusion, this one and all those things.
Images, basically.
Honestly speaking, I don't believe that there is something which they say I will not ask. Though Saikat is saying that clearly said in some prep course that they will not ask MRI, they will not ask transplant. Though transplant, the part was there in the November 2022, if you remember.
Transplant in details they will not go because
yes. But it was a part of the question in the vignette in 2022 only. Now, if you ask me, Abhi, I never thought when I would give my exam in 2016, they would actually ask me an SSEP. Okay, it was not a part of CBS. It was not a part of CBS. It was a part of CCS, and there was an SSEP, a nerve conduction ka some image, and I went crazy beyond it. And then that examiner was like, "Just calm down, look at it, you know the answer."
The other thing,
the vignette had the answer. I did not even need to look at the image. So when I answered, he was like, "See, I told you, you don't need to look at it."
The other thing people are talking about the gender difference in intensive care medicine. Please have a read. Many articles got published in the intensive care medicine journal. They can ask in one of the vignette, maybe a small part. Why to meso spot? Because these are being discussed extensively all over the world. And I don't know whether they will ask about artificial intelligence or not. No need to read, but yes, read about the this one, brain death. Okay, the European guideline, the European resuscitation guideline, trauma guideline, brain trauma foundation, the latest one, and also the 2020 modification with the decompressive trauma guideline of the mechanical ventilation in trauma patient. The coagulopathy guideline, the newer one, not the older one. I think that it is a 5th edition or 4th. Please Google, you will find it. They will be asking something from there. They every time they ask from there only.
Doctor, can you kindly share all these guidelines?
Slowly, don't worry. So I've shared one on the acute pancreatitis. I'll keep on sharing.
Okay, good. Thank you.
But whatever you do, just Google. Whatever topic you're reading, just write European guideline. Acute pancreatitis, European guideline. Heat stroke, European guideline.
Another point of possible pattern recognition from your experience as an examiner, we can make short video like as you mentioned in the beginning, trauma, hypocalcemia, it will be abdominolysis.
No, doctor. Samyogita has told that she'll share a data set, which I have already shared to her. You go through that.
I'll
Okay.
share today itself. I'll share.
Yeah, you go through that. You don't need a video. Probably if I prepare a video, I'll be preparing based on that data set.
Thank you so much. Good.
You're
Okay,
in the Kriti Learn group now, WhatsApp group.
In the edit group.
He should be there.
Edit group.
Yeah, he is there.
I'll share right there.
In that group. He's there in that.
Okay.
Yeah.
We
And
alert
when
on
you-
that group. We are putting some brain teasing. Sekat is putting a lot of effort to keep your brains active.
Yeah, and also important thing is that when they ask to summarize a case, no need to always say 55-year-old comorbidities, blah blah blah, because you are wasting time. Like in the now the thing is that you someone I think one of you have asked whether we have to mention comorbidities or something like that or not. Now you have to, that 10 minutes is very crucial. From the vignette you'll come to know what will be the subsequent vignette. Lagbhag kya hoga. So if in the vignette, if you see the patient is from, we got something like that, low level care nursing home, psychiatric patient, not compliant to medication. How can you summarize these 3 lines in one sentence? That will come in the summarize because that is important. How will you summarize what I have told, these 3 lines into 1 line? Low level care nursing home, non-compliant to medication, and what the third one I mentioned is slipped my mind. Anyways,
And try to tell where you are going to admit the
psychiatric
patient,
patient.
whether it is continue.
Sorry.
Poor self-care can be.
So the easiest way, complex psychiatric background with poor baseline function.
GCS.
Poor baseline function. Low level care nursing home means in Western world, what do we do when the patient is long standing in hospital, in our ICU or in hospital, we shift the patient to low level care nursing home. So that by rule, it means the patient has got very poor level baseline function and they're very frail. You can say the patient is frail. Summarize, that's all. No need to say 55-year-old, those and those. No. So you have to make it crisp. That 10 minutes will help you. Once you start, once you summarize, or the first initially they have summarize. In most of the vignette, they will say summarize your findings. You have to smash it out of the park. Once you smash it, the examiner will know that this candidate will be able to answer at least more than 50% of what we'll be asking. So utilize that 10 minutes wisely. Write it down before exam, before starting the scenario, show it to the examiner. I've got a blank paper. You'll get all instruction from the ESICMs in the subsequent days. I've got a pen, no camera inside. Just open it and show it to them. Is it okay to use? Take the permission. Please take the permission. They will say yes. Write it down. Because it will help you in the subsequent vignettes. And nobody can predict what they will be asking. Something they will be asking what they have seen in their own ICU. They will pick up that case. It can be anything. So it's very difficult to predict what they will be asking. But yes, in CBS, you can predict. You have to know this pattern. You can answer that. Anything? Any other feedback? How we can improve? Anything we can improve? We have told many things, how you can improve. Now it's your time to give us feedback. Dr. Samagita, you want to tell something? Are you there or you have left?
Exactly. Already very good. There's
no, because they have given so many exams, maybe something from your experience level. No one can be 100% right. There is always a scope of improvement.
So, if like we can do one thing for mock 3, we can make it exactly like if they give 5 vignettes in the main exam, let's not make the cases this long, because here unnecessarily we were missing, so we didn't have the real idea. Now I am in a belief system that exam it's going to be short, I'll complete it.
Yeah, it will be 6 to 7 vignettes.
But try to keep it as like the second short case was very long. So if we keep it exactly like the exam, so we'll exactly know that are we being able to finish our exam or we are still running behind time.
In ESIC, I've got few questions from the previous. In the short questions, they have at least 5 to 6 vignettes. So it's very difficult to predict and it's quite extensive. When I gave the exam last time, we never reached in most of the cases, most of us to the last vignette.
Okay.
Even in the short case.
So it can be this long also.
So roughly they say in the long case, it can be 5 to 7, around 6. In the short case, it can be around 4 to 5. Yeah, I agree. In the mock 2, there is the first long case has got 9. That's okay. We want to include all possible informations.
Right. Okay.
I have another idea. If during the third mock, if possible, we can make it interactive. If there is any point or weakness, you can comment.
We can't do it. You mentioned it during this time. We can't do it because when you are also giving and the person who is taking exam is really exhaustive. It really switches one off. Not possible. What we can be interactive only during this live debriefing. That's why we kept
more
it
beneficial for us if you are interfering direct. So in real situation, we have some idea.
So the time factor that we are timing it every 25 minutes, 10 minutes, or whatever, 15 minutes, it will not be there. You need to know the time pressure. Time pressure is very important. That's you have to prepare. You can do it by yourself. Just sit in front of the mirror and answer to yourself. You can just go to the same questions, try to answer. Thank you for letting us know that about the vignette. We'll look into that.
See, we are exhausted, but I mean, gross hoga, so we will definitely tell small, very gross stuff, but detailed feedback, it gets exhausted at 2.5 hours.
And in that process, we'll forget the things also, because at that time we are too much into the exam.
Correct.
Don't remember anything of that.
You have to have that feel of. Anyways, you do get a short feedback about your whole thing, how you have attempted and all.
I do write when you people are answering. I keep on writing what the negative and the positive point.
You gave me a feedback, right?
Yeah, I give feedback to everyone.
All of us are giving a feedback to everybody.
Yeah, so I give feedback for 15-20 minutes. I write down in a piece of paper even that my brain has got limited space. I can remember everything. So I have to write it down. Okay, these are the positive and the negative. I have mentioned everyone what's your positive and what's your negative. So that's why I use the Pendleton method of feedback. That is the one that we use in Australia as well, because that is a way that one can learn their mistake and can improve.
Ma'am, how should we prepare for these last 20 days left now?
Maybe just guidelines and more practice, because guidelines is what the vignettes will be based on.
Okay.
Yeah. Because see, you have cleared EDIC 1, you know your stuff. Okay, I think more of guidelines and more of practice.
And crit IQ at least twice you will get 2 questions from Crit IQ.
The biochemistry or the images and all?
Everything.
Okay.
I only actually with these duties and all, I only got 2 days to finish. I only read once, but from that I can tell you I got only 2 questions.
So I'll do the Crit IQ as many times as I can.
Bala's book you have to do. Bala's book is mainly for our fellowship exam here, but you can get 1 or 2 questions from Bala's book as well. Bala Venkatam. So these 2 things if you do, and later on if you can just pick up random in Crit IQ, you can randomly pick up 10 questions or 12 questions. Try to pick up more questions, reduce your time, and try to answer the 12 questions in 10 minutes or 8 minutes. That's how you'll develop the speed. It's more of exercise, nothing else. Once you recognize the pattern, like refeeding, all the electrolytes are low, refeeding. No need to go to everything.
Okay.
Got freezed. You got freezed, is it?
Oh, who?
I couldn't, or maybe I lost connection.
Oh.
So I think we'll wind off.
Yeah, I think we should wind up, and it's already for me is 1 a.m. 12:30 a.m. Best of luck for the mock 3. We'll be starting from next week. We are doing some minute revisions. We have to go through that before we finalize, and we'll again conduct a live debrief for the mock 3 as well before the exam.
So we'll try a live debrief, but we will also try a meet and greet for everybody who's not taken the live mock also. Just general, what to expect, what not to expect. So let's see how we can plan both together.
Yeah.
Together
Let's put the live debrief. As of now, we'll think of that. More important that you people, most of you are giving mock 3. I think so. We'll see how it goes. But from the next week, we will be starting the mock 3. Maybe midweek.
Okay.
Okay.
Thank you so much.
Okay. Yeah. All the best. All the best.
Thank
Yeah.
you. Good
Thank
night.
you so much.
Yeah. Bye bye.
Appreciated.
Thank you.
Thank you. Thank you. Thank you. Thank you. Thank you.